Yes. We wish each one of them good morning, good afternoon, good evening to all the participants. As we are joining, we are going to start second day of the conference, virtual conference on physiotherapy, physical rehabilitation, and sports medicine. I'm especially thankful to Mr. Kevin Brown, who handled his heavy burdens, duties, and responsibilities to make this event happen today. I would like to thank participants, especially those who are joining from miles and sharing your valuable experience and ideas. With a good number of participants, I am sure this day 2 of the conference will be highly educational and not to miss the event. This webinar aims to provide aid for people to share analysis and results about all features of physiotherapy, physical rehabilitation, as well as sports medicine. So this conference will be covering just like topics like sports physiotherapy, physical therapy science, artificial physiotherapy methods, women physical health, as well as palliative care, experimental technique in physiotherapy, yoga and physiotherapy, acupuncture, physiotherapy, and yoga. So make sure to introduce everyone at the beginning. Ensure that you have clean work approved background. Look into the camera when talking instead of looking at yourself. Be aware of your audio and as well as video settings. Now I would request Dr. Mohammed Asim from Rifa International University from Lahore campus from Pakistan to start with opening speech. Yes, sir, you can start.
Thank you very much to
Remaining
the
will be joining it.
Inovine meetings and Mr. Kevin for letting me in into this second day of the conference. I would like to introduce myself. My name is Dr. Mohammed Hashim, and currently I'm working as assistant professor and clinical head at Rifa International University, Lahore campus in Pakistan. And it would be great to share my today's findings with you. And I would like to share the my paper that it was a randomized control trial and it was effects of dry needling on pain and function in anterior and ankle impingement. So this was a study which we had recently completed few months ago. I would like to give you a brief introduction about the variables. That the first variable is dry needling. I'm working as a physiotherapist for last more than 8 to 10 years, and I am practicing dry needling for last 5 to 7 years in my clinic as well. I teach at my university as well. So dry needling is basically a treatment technique in which we use a dry needle for release of the trigger points. And in a single dry needle, it's a like you can say a single fine filament needle which we insert on the trigger point to decrease the pain, and we also release the myofascial trigger points as well. So this was a bit introduction about the dry needle. We had focused on the anterior ankle impingement. That's why we have to see that how the dry needling is affecting the anterior ankle impingement. So it is a basically condition in which the individual experiences pain in front of the ankle due to scar tissue and inflammation or bone spurs that form in the anterior of the ankle joint and limit range of motion and the function. So this process is developed because of the repetitive strain on the front of the joint causing pain, limited range of motion, and it may or may not be causing the chronic ankle instability as well. So this is basically anterior ankle impingement. We had included various studies. One of the study was the Stoichev et al. In 2020, in which they had used the dry needling as a treatment modality, and in which they had found that dry needling has effects on the tendinopathy, and we can use this in the future as well to see the results as well in the future research. Another study which we included was of the Laker et al. In 2020, in which they had seen the short-term effects and immediate effect of dry needling in the triceps muscles to see the function and range of motion, and in which they had seen that although their findings were not promising for the dry needling use in terms of functional and range of motion as well. The rationale of my study is that very few studies have been done so far to see the effects of dry needling in anterior ankle impingement. Therefore, the main purpose of my study was to see the effects of trigger point dry needling on reducing pain and improving function with anterior ankle impingement. And I have compared dry needling along with conventional physiotherapy to find the better outcomes as well. And the objective of my study was to see the effects of dry needling on pain and function in anterior ankle impingement, and also on the range of motion and functional outcomes as well. There were two hypotheses. Alternative hypothesis was that whether dry needling is more effective than conventional treatment in improving pain and function, and the null hypothesis that dry needling is equally effective as conventional treatment in improving pain and function. This study was conducted at Services Hospital in Lahore, Pakistan. It is one of the biggest tertiary care hospital in Lahore, Pakistan, and we had included the 31 patients, 62 patients, 31 in each group, and we had calculated sample size by using EPI tool, and we had used the convenient sampling technique in my study, and this study was a randomized controlled trial. For the outcome measure tools, we had used foot and ankle disability index, goniometer for the range of motion, and numeric pain rating scale to find the level of pain. And and ankle disability index was used to see the function of the ankle joint. And we had included the patients with pain and stiffness, active trigger points, post-traumatic stiffness, pain with movement, and pain limited range of motion in 2 months. And we had excluded those patients which had needle phobia or any cognitive defects, open wound, and no more than 40 years age, and impingement due to any bony or structural deformity. We had excluded those patients. So there were two groups. In the treatment group or the interventional group, we had used the patient, we had applied the dry needling along with the conventional physiotherapy, and and in the control group, we had applied the conventional physiotherapy in which we had used the hot pack and massage techniques along with the stretching techniques as well. The data analysis was done by using statistical package for the social sciences version 21, and we had used Shapiro-Wilk test for the normality and uniformity, and independent sample t-test for determining the significant differences between the two groups. And Bitterway and ANOVA was also used to see the significant differences in each group, and frequency tables and pie charts for the descriptive analysis. And the difference of p-value was less than 0.05 was considered as significant. This was the consort diagram, and in which we had allocated the patients and the randomization. Now come towards the result. Firstly, I would like to give you the result that the mean age was 30.53 for the group A and 30.73 for the group B, and the BMI of the group A was 23.33 and group B was 26.0. And if we are talking about the gender, mostly in group A, 73% were males and 26% 0.67 were females, and in the group B, the 80% were males and 20% were females. So we had applied the independent sample t-test for comparison of FADI, functional ankle disability index, that showed that before treatment session, p-value was 0.121, indicated as non-significant difference. All three post-treatment sessions with p-values less than 0.01 indicate statistical significant difference results. And as you can see in the table, that in before treatment and after treatment succession of first session, second session, and third session, the mean values are increasing of the functional disability index. In the histogram chart, you can also see the comparison of the dry needling as compared to the control group in terms of FADI, the functional ankle disability index. And you can see successively the score is increasing before treatment and successively after first session, second session, and third session. So it is showing that the functional disability index is increasing in successive sessions, which means that the dry needling, although the control group is also having an increase, but as compared to the dry needling, the increase in the dry needling is much more than the control group. Another, we have compared the numeric pain rating scores in before treatment and successfully after first, second, and third treatment session. The independent we had applied some independent sample t-test for comparison on numeric pain rating score, It was shown before first treatment session, first and second post-treatment sessions was p-value more than 0.05 indicates statistical non-significant difference, while the third post-treatment session with p-values less than 0.05 indicates the statistical difference in the pain values. We have also found the range of motion, as I have told you earlier, that we had used a universal goniometer for the range of motion. We had seen the effects on the plantar flexion. So independent sample t-test was applied for comparison of plantar flexion. It was shown that before treatment and all three post-treatment sessions with p-values less than 0.05 indicates significant results. And in the table, you can also see the mean values, which are like in before treatment session and after first, second, and third treatment session, the range of motion is increased from 27.1 to up to 46.0. So in both treatment groups, the results were significant, but in dry needling, they are more significant. And in we have also applied the independent sample test for the dorsiflexion. Uh, so for comparison of dorsiflexion, it was shown that before treatment and first treatment session with p-value 0.00 indicated statistically significant difference, while second and third post-treatment session with p-value more than 0.05 indicated statistically non-significant difference. We had applied the ANOVA test to pairwise comparison of the foot and ankle disability index study in the comparison of dry needling and control group. So pair one comparison showed that the extracted repeated ANOVA, repeated Meyer ANOVA showed that FADI, foot and ankle disability index, numeric parenting scale, plantar flexion, and dorsiflexion was improved at all three post-interventional assessments in both groups, that is dry needling group and the control group. So these were the results which which I have shared with you for my study. Now I would like to continue with the discussion section of my study. So the motive of this study was to compare and discover the effects of dry needling therapy and conservational therapy on pain and functional outcomes of patients with anterior ankle impairment. And we have compiled the discussion. Few studies have agreement with our study. Few studies have disagreement with our study. A study is I have completely included in my article, that is in agreement with my study, that which was done by Nazina et al. In 2018, in which adjunct findings about the demographic values, those are similar to current study findings, that how anterior ankle impingement occurs in young non-obese patients. The mechanism is obvious that normal or less body index, more mobile and actively individuals become that lead to potential impairment followed by soft tissues injuries. A study another we have included that it is in disagreement was done by Amoko Teo et al. In 2017 shows findings that conclude that anterior ankle impingement is directly proportional to increasing weight. More recently, the effects of dry needling in lower extremities are being studied in the neurological population as well. Another study which I have included in my study was that done by, which is in agreement with my study, that done by Salom Moreno et al. Found that a single session of dry needling decreased spasticity as well as widespread pressure pain sensitivity in subjects with spasticity post-stroke. So this I also included one of the study in my literature as well, which had a short-term effect on the of the dry needling on the pain and function as well. So this was the discussion of my study, and let's come towards the conclusion of my study. So this study provides evidence that the inclusion of trigger point dry needling within the lateral peroneus muscle resulted in the better outcomes in pain and function. And at the end of the three treatment sessions, maximum improvement was seen as compared to the end of first and second session in individuals with enteric impingement. Our results may assess that the benefits of trigger point dry needling in the lateral peroneus muscle for the management of the ankle impingements are clinically relevant. Significant differences are observed in all three outcomes. Further studies should examine the long-term effects of these interventions in this population. So these were the references Any question and answers are more than welcome. The time frame which was given to me was for almost 20 minutes, so I have concluded my session in the time frame. And I would like to share my experience of the dry needling that I am applying this treatment for quite a long time. And I would suggest that if we are talking about the dry needling, then if we are expecting the results quickly, then in some conditions, especially the myofascial conditions, the results may come into the first session. But in my experience, what I have seen that rather than the short-term outcomes, you have to see the long-term effects of dry needling as well. And whatever I have searched on the dry needling, it has the short-term outcomes. So for me, this is not a complete treatment for the patients, but rather it's one of the treatment options which you can use on the patients which are having myofascial pains. Although the study was on the anterior ankle impingement, but I am sharing my personal experience with you that what I have seen for the dry needling. So any questions at this platform are more than welcome. If you want to ask any question, and once again, I'm really thankful to the organizers of today's session, the Inovine Scientific Meeting, for inviting me and to share my expertise with you. I wish that these sort of activities must continue in this pandemic situation and in the future as well. And I must say that whenever in the future these conferences are held internationally, so I would like to visit and physically and to present my expertise in the future as well. So once again, thank you very much for letting me this opportunity. Any question?
Yes. Yes. Any questions to Dr. Hasim? I think you are going with holy month, sir. Within this month, you are going to start with holy month.
Sorry?
You are going with holy month. Holy month, Ramadan.
I'm not getting what you're saying. Can you?
Yes, yes, yes. Any questions? Any questions? Any questions to Dr. Mohammad Hasim? So thank you very much, sir, for participating in this event. On behalf of organizing committee member of Physiotherapy Congress 2021, we want to thank you for your instant presentation. Looking forward to meet again next time.
Thank you very much.
Yes. Just if you have any questions or comments, you can text here so that we can ask behalf of the participants. Just you can text in chat box. Next will be now I request Dr. Vidhi Thakur from Ashok and Rita Patel Institute from India, from University of Gujarat to start presentation.
Hello, everyone. It's a pleasure to meet you, Madhu sir.
Yes, madam.
I'm very happy to be participating in the virtual scientific conference, which is a second, I suppose. I'm very much grateful to the Inovine scientific meetings to permit me to present my research workflows in such a well-organized platform. Hello, everyone. Today I'll be presenting my research work, which has been conducted by me and my team about agreement of counting talk test with 1 repetition maximum and session rate of perceived exertion in measuring intensity of strength training session. We all know that resisted training to improve health and fitness has now become an essential part of physical activity guidelines for individuals of all age groups. But to plan and prescribe such a resisted training program, we need to assess the strength of a muscle. There are various tools available which helps in determining the strength of an individual muscle. The gold standard is 1RM. It's a reliable tool to measure the strength of the muscle irrespective of its location or gender. But due to multiple attempts, as well as the rest in between the attempts, it's quite time consuming. It requires space and lots of equipment, so it is expensive. And it also requires skills and expertise on the part of assessors. So we dwell into other tools as well, one of which is rate of perceived exertion. It is an easy and reliable tool, and if given time, some passage to pass around, it becomes less influenced by the terminal portion of the workout. But it is a subjective tool, so it's more likely for a novice user to under or overestimate the intensity of a strength training program. Since we had this tool, we thought what relationship these two tools have with each other. According to Berkeley and Borg, they estimated that if one is at 65% to 75% of 1 RM, the CR10 scale will be between 5 to 7. In opposite to that, when L. Bowie conducted a study, they found that RPE, which was quoted at the actual load lifted, was very low. So the agreement also found to be low, especially in the training zone of the resisted training program. So we looked for other tools as well. And we found that lactate threshold tool is also an established one to assess the strength of a muscle. But being invasive and expensive, it is not quite commonly utilized in a clinical setup. But it do holds a relationship with a counting torque test. Counting torque test, when it is administered at 1/2 to 1/3 of the resting counting torque test value, it lets the individual to work at moderate to vigorous level of intensity of aerobic exercise as per American College of Sports Medicine. So what is this relationship we found? According to Timothy J. et al., lactate threshold, when we found the value of VO2 max and that of heart rate, Timothy J. Quinn observed that the value of VO2 max and heart rate at ventilatory threshold quite underestimated the values of the same at all the three levels of counting torque test. Whereas when lactate threshold was been measured and the heart rate and VO2 measured at the same point, more closely represented positive and equivocal torque test. This is the reason we thought of evaluating the feasibility of counting torque test in prescribing the intensity of resisted training session. So when we were looking for it, we came across our research question that to determine the intensity of a strength training program, especially in a clinical setup, is quite challenging given the drawbacks of the already established tool. So we need to dwell into counting torque test and look for its feasibility. So the objectives of our study is to find out the degree of agreement between 70% 1 RM and counting torque test, as well as of session RP and counting torque test for determining the intensity of strength training session. We pose the hypothesis, which is the null hypothesis, that while determining the intensity, 70% 1 RM and counting torque test will have no or poor agreement. Whereas for the alternative hypothesis, they will have moderate or excellent agreement. For session RPE and counting torque test in terms of null hypothesis, we projected that they will have no or poor agreement. Whereas for alternative hypothesis, we pose that they will have moderate to excellent agreement. So this is a pilot study conducted in a university fitness center with a convenient sampling method with a sample size of 30 in individuals of 18 to 35 years of age groups who provided negative response to all the questions of physical activity readiness questionnaire and were regularly participating in moderate to high level of physical activity with a body mass index of 18.5 to 30 kg per meter square and who were ready to give a personal statement of not having smoked in the last 12 months. We excluded those individuals who had any limitation which will prevent them from performing the exercise required in the study, those who had underwent any kind of surgery recently, or who were pregnant or were taking any sorts of medications. We performed the procedure in 2 different days. On the first day, we determined 1 RM by going through a warm-up session, and after which we permitted the participants to go through 4 attempts with 3 minutes of rest between each attempts. We determined the RM for 4 different exercises, which is lateral shoulder raise, chest press, leg press, lateral pull down, followed by which a cool down was been given to the participants. After a break of 48 hours from the testing, we familiarized the participants with counting torque test and CR10 box scale, which were been recorded as well at the end of the session. In the weight training session, the participants were required to perform three sets of 8 to 10 repetitions in a circuit fashion at an execution speed of 1:1. At the completion of session, the CTT and RP was recorded. RP session was recorded at the end of 15 minutes, followed by a cool down was performed in a passive form. These are the exercises and the instruments which we utilize during the session. For data analysis, we calculated percentage of CTT, averaged out the 70% 1RM, we calculated percentage RP. To determine the type of distributions our data had, we performed Shapiro-Wilk test. We established agreement to be being percentage CTT being within 10% plus or minus of percentage RP and of 70% 1RM. The agreement was further analyzed by utilizing Blunt-Altman plot method as well. The p-value was set at 5% and confidence interval was at 95%. These are the descriptive statistics of our participant population. We found out that the level of physical activity performed them mat minutes per week was 4,152, and the level of load lifted by them while determining 1RM ranged from 6 kg to 46 kgs. The percentage of CTT which they opt in at the end of the session stand to be at 30%, whereas percentage RPE stand to be at 30% and percentage CTT stand to be at 27.96%. So, our result and discussion of the study. We verified the agreement first between percentage CTT and percentage RPE and found out a mean difference of negative 2.17, which suggests that percent CTT underestimated the intensity of resisted training session by 2.17% as opposed to percentage RPE, which is within the acceptable limit set by us of plus or minus 10%. But when we are looking at this Blunt-Altman test, as you can see, the red line depicts the mean difference, whereas the two green line depicts the limit of agreement between all the data sets of 30 participants. We found a statistical significant difference when we were looking for agreement between percentage CTT and 70% 1RM, with a mean difference of negative 42.04. Similarly, for agreement between percentage RPE and 70% 1RM, we obtained a mean difference of negative 39.33%, suggesting that both of the tools, percentage RPE and percentage CTT, underestimated the absolute intensity of the resisted training program, which was set at high level, whereas percentage CTT and percentage RPE informed that the resisted training session was of low intensity. In this study, we had recruited 15 male and 15 participants female. So we had an equal ratio. All of them were more likely to belonging to the physiotherapy background. They performed regular physical activity either at home or in gymnasium. It included resisted as well as aerobic protocols. While performing these protocols, one of our participants did end up with soreness in the pectoralis major muscles bilaterally, as well as pain in the anterior joint line of the shoulder with an NPRS of 5. It was immediately treated with an ice application of 10 minutes over bilateral pectoralis major and a grade 1 Maitland mobilization of the shoulder. And at the end of the session, the NPRS of the patient was quoted at 0. Participant didn't have any complaints thereafter and was able to participate in this day 2 session. Participant was regularly performing aerobic exercises pertaining to lower limb. This might be one of the reasons why the patient ended up with a post-session joint pain and soreness in the upper limb musculature. In a study by Ferrari et al., 1RM weight lifted during leg press exercise was found to be much higher than it was found in our study. It also showed that 1RM weight lifted during chest press, chest press, lateral pull down, and lateral shoulder raise was lesser than our study. But in opposition to that, Dong Isu et al. Conducted a study in which the weight lifted was much higher than quoted in our study. Now, this difference amongst the different study findings and our finding can be attributed to the biomechanical, neuromuscular, and histochemical differences, especially in the upper arm functions of men and women, as well as the difference in years for which they have been training themselves, the occupation which they have, and the genetic build of that individual. We also found that there is no agreement or poor agreement between 70% 1RM and percentage RP, because we found that at 70% 1RM, RP was 3, which is also similar to the findings of Egan et al. And Jenner et al., suggesting that the level of agreement is poor between these two tools as well. The limitations which we think would have affected the results and the findings is because we chose the exercises depending upon their availability at our setup. We had included university students, most of them who were belonging to our physiotherapy background. We didn't control the confounding factors like mode of trainings, year of training, or nutritional status of the participants. And apart from one entire resisted training program, no other follow-up or additional training sessions was been given to the participant. So I suggest that in future, there needs to be a study which conducts to understand the factors affecting counting talk test to further dwell into the matter of its feasibility in determining the intensity of resisted training program. So the conclusion of our study is there is no agreement between 70% 1RM and percentage CTT. There is an agreement between percentage CTT and percentage RP. We can utilize it in the clinical setup as an adjunct tool to RP. But still, whenever you're utilizing an RP or CTT in a clinical setup, it should always be given with caution, given there was a huge difference in the level of agreement between them and 1RM. These are the references. If there are any questions, please do let me know.
Questions? Any questions to Dr. Viditapu? Just if you have any questions, you can text in chat box. We'll be asking behalf of you. Unfortunately, we have only few members. They'll be joining according to their timings, madam. They are joining according to their timing, and they'll be delivering the talk and they'll be leaving.
Oh, is it so? That's fine, sir.
Yes, yes. Yes, after 1 or 2 hours, there'll be so many members will be joining, because according to European as well as some African
difference in the timing zone
yes,
might be the reason, sir.
Yes,
Yeah.
yes.
That's fine, sir. I'm really thankful for the Innovine Scientific meetings to give me this opportunity and a platform to present, so I can share my research work with all the colleagues over there. Thank you so much. Have a good day, everyone. Bye-bye.
Thank you very much, madam, for participating in this way.
Yeah.
On behalf of organizing committee members of Physiotherapy Congress 2121, we want to thank you for inside presentation. Looking forward to meeting next time in physical event if everything goes well.
Absolutely, sir. Yeah. Have a good day.
Yes, thank you. Thank you very much. Now I would request Dr. Naurup Kaur from Rayat Bahara University from Punjab to start the new presentation, as it is the second talk from madam's presentation. Yes, madam. Just you can start your presentation by uploading your PPT. Yes, doctor. Yes. Thank you. Thank you very much. I request all the participants, those who completed the talk, just be on in online. Just you can ask the questions because it will be encouragement to all the speakers, those who are giving one by one. Because as soon as you complete your talk, just you are living, and it will be a somewhat discouragement to other speakers. I request all the participants, as soon as you complete, just be online and just you can ask the questions. Yes, madam, you can start your presentation.
Factors like age, smoking, higher body mass index, earlier age at menarche, and larger the heavier menstrual flow, familial history of the dysmenorrhea, depression, and stress are the risk factor for the primary dysmenorrhea. And other common factors included are education level, marital status, employment, and alcohol consumption. There are the common signs and symptoms of primary dysmenorrhea are the pain is the spasmodic type and it's mainly located in the lower abdomen, sometimes radiated to back and the medial aspect of the thighs. Systemic discomforts like diarrhea, fatigue, nausea, vomiting, and headache may present, and it may be associated with the vasometer changes like pallor, cold sweat, and occasional fainting. Rare syncope and collapse in severe cases may be associated. And then the pathophysiology, this appear to be multifactorial. There are several theories that likely that an individual may have an primary dysmenorrhea. These includes uterine contractions and vasoconstriction, modulation and stimulation of pain fiber, behavioral and psychological factors. In uterine contraction, the uterine contractions and vasoconstriction theory currently has the strongest scientific basis, disintegrating endometrial cells, releasing the prostaglandins F2 alpha, a myometrial stimulant and vasoconstrictor. This mediator prolonged uterine contractions and reduced blood flow, which is postulated to cause the pain. Women experiencing primary dysmenorrhea have an abnormal pattern of contractions with higher basal resting tone. Elevated prostaglandin levels are found in the endometrial fluid of women with dysmenorrhea and correlate with the degree of pain. And the stimulation of pain fibers in the uterus causes activation of afferent pain fibers transmitted up to the central nervous system. In addition, there are some evidence of direct effect of pain fiber on the pain fibers themselves in case of dysmenorrhea. This theory is based on potential effect of ischemia, and it is thought that type C pain neurons are stimulated by anaerobic metabolites generated by an ischemic endometrium. It has also been suggested that leukotrienes can increase the sensitivity of pain fibers. The multimodal response to the pain are the impact of Psychological and behavioral modification on dysmenorrhea is yet to be fully understood. There is general consensus that primary dysmenorrhea often coexists with other pain conditions such as dyspareunia, irritable bowel syndrome, and fibromyalgia. This is the pathology of the primary dysmenorrhea, and the objectives of the study are to review. This is a review type of study. The objectives are to check the prevalence of primary dysmenorrhea in young females and gather robust evidence for the effectiveness of physical activity in management of pain and improving the quality of life in females with the primary dysmenorrhea. And the need of the study was primary dysmenorrhea is the common gynecological disorder affecting approximately 20 to 90% of women in their reproductive age. It affects the academic performance, social, psychological, sports activity of the girl students, thus affects the quality of life of young female. The most common effect of primary dysmenorrhea on daily routine of girl student is prolonged resting hours followed by inability to concentrate on studies which lead to absenteeism from school or work. This study is done to find out the evidence on effect of physical activity on primary dysmenorrhea for reduction of pain, stress, mood changes, and to improve the overall health status. And methodology, in methodology, the searches have been done using various electronic databases, like electronic searches were performed using database Medline, Ambase, and the Physiotherapy Evidence Database and Cochrane Library. Randomized controlled trials and cross-sectional studies were searched using keywords primary, dysmenorrhea, prevalence, knowledge, physical activity, exercises, quality of life, effectiveness, physical interventions, either individually or in various combinations. Google search and hand searches of reference list of existing articles were also conducted to find papers that did not appear in the main database, and the searches covered the literature from February 2006 to the March 2009. In inclusion criteria, the studies comprising the female subjects having the primary dysmenorrhea within their reproductive ages, and the study with the full text published articles, and the studies published in English language were included in the studies, and the studies comprising the females having identifiable pelvic disease or any other gynecological disorders are excluded, and unpublished articles and only abstracts were excluded. 30 articles were identified from the electronic search. 21 articles were selected for the full text reading based on inclusion and exclusion criteria. Out of these 21 articles, 15 were randomized control trials and 5 were cross-sectional studies. Only 6 studies have been identified from the India, including prevalence and effectiveness of physical activity, and other 15 studies were conducted in the Iran, Indonesia, Egypt, Medina, and Turkey. These are the results by the authors like Agrawal et al. Founded in their cross-sectional study in Gwalior that the prevalence of the primary dysmenorrhea was 79.67%, and Shah et al. In their cross-sectional type of study done at the Mumbai found the prevalence rate 45%, and Kural et al. Also done a cross-sectional type of study in Indore and found 84.2% prevalence rate, and Kanjanban et al. Done a cross-sectional study and found 76.0% in the Manipur, and the Karnath et al. Also done a cross-sectional study in Karnataka and found the 62.5% prevalence rate. The author Abaspo et al. Done a study to determine the effect of exercise on primary dysmenorrhea. The study was a randomized controlled trial of 150 high school girl students in a Maj Solomon city that suffering from the severe dysmenorrhea. Students were separated into 2 groups, that is exercise and non-exercising groups were registered. Exercise group were educated about 3 types of exercise activities. Lie face up with legs and knees bent, perform the abdominal breathing for about 10 minutes, stand holding back of chair, lift one heel off the floor, then the other, repeat 20 times, then stand holding back of chair, then do 5 deep knee bendings. They should do these exercises twice a day and stop them in menstruation. And their results found were the results showed that the intensity of pain in exercise group declined from 8.59 to 4.63 in the third period and 2.5 2.84 in the fourth period. The average of duration pain declined from 7.15 to 4.22 in the third period and 20.2.23 in the fourth period. The average of using sedative tablets also decreased from 1.13 to 0.35 tablet in the third period and 0.0 tablet in the fourth period. And they concluded that the findings of the study revealed that the exercises can decrease the duration and severity of dysmenorrhea and also using of the sedative tablets in the high school. Jade et al. Assess the effect of term of stretching exercises on primary dysmenorrhea in high school students. 179 single girl aged 15 to 17 years with moderate to severe primary dysmenorrhea were selected from 6 high schools located in 2 different city zones. The students were non-athlete and volunteered for the study. The participants were randomly divided into 2 groups. One was experimental group comprised of 124 females and the control group comprised of 55 girls. In the intervention group, the subjects were requested to complete an active stretching exercises for 8 weeks, 3 days per week, 2 times per day, 10 minutes each time at home. In pre-test, all the subjects were examined for pain intensity, 10-point scale, and pain duration and use of sedative tablets in 2 continuous menstruation cycles. After 8 weeks, pain intensity was reduced from 7.65 to 4.88. Pain duration was also decreased from 7.48 to 3.86 hours, and use of sedative tablet was decreased from 1.65 to 0.79 tablet in the experimental group. In the control group, a significant decline was also noted for the pain duration. And in conclusion, the findings of the study revealed that the exercise can decrease the duration and severity of dysmenorrhea and also using of the sedative tablets in the high school. And the next study done by the Judge et al. To assess the effect of one term of stretching exercise on primary dysmenorrhea in high school students. The total is 179. The third study was by Azima et al. To investigate the effect of isometric exercises on intensity and duration of pain and level of anxiety among students with the primary dysmenorrhea. In this randomized controlled trial, 68 students living in dormitories of the Shiraz University with primary dysmenorrhea were randomly assigned to both isometric exercise and control group. Pain intensity was measured using visual analogous scale. The protocol of isometric exercise for intervention group was supine lying, bending knee and thigh, putting a pillow between 2 knees to each other, hold for 5 seconds and then relax. In supine lying, putting the hand below waist and pressing the waist to ground, 5-second hold and relax. Then supine lying, again in supine lying, bending knees and thighs and trying to move head and neck toward the right thigh and hold for 5 seconds and then relax. Pain intensity and duration of pain was significantly reduced in exercise group, and however, no significant difference was found between 2 groups concerning the mean anxiety levels. The findings of the study revealed that isometric exercises seem to be an easy non-pharmacological method for reducing the primary dysmenorrhea. And the last study by the Patel et al., the study to see the effect of knee to chest position in primary dysmenorrhea in school-going girls. In this study, 15 subjects were selected in the age group of 12 to 15 years with primary dysmenorrhea on the basis of inclusion and exclusion criteria. which received alternate knee to chest position in supine line. Duration for first to fourth week, 20-second hold and 10 repetitions progressive, and fifth to eighth week, 30-second, 20 repetitions, 3 days per week. Pre-assessment of subjects were done on the first day of the menstrual cycle, and post-assessment were done on the first day of third menstrual cycle using the NPRS, VMSD, and MMDQ scales. There was extremely significant difference in the pre and post mean of these readings, and the knee to chest position is effective in reducing primary dysmenorrhea after 8 weeks of intervention. In discussion, primary dysmenorrhea is not a real threat of life, but it can affect the quality of life in females. In many countries, primary dysmenorrhea is the main reason for recurrent short-term school and work absenteeism in young girls and women. Therefore, different methods of treatment for primary dysmenorrhea have been prevalent. The recommended treatment method to reduce the severity of pain in primary dysmenorrhea include the use of NSAIDs and other medications like analgesics, but the side effects from such medications are well known, like nausea, breast tenderness, intermenstrual bleeding, dizziness, drowsiness, hearing and visual disturbances. During the past 30 years, exercises and physical activities have also considered as an effective treatment for the prevention and treatment of primary dysmenorrhea. Though through this review study, we identified several physical activity interventions like isometrics, core strengthening, stretching, and aerobic exercises, knee to chest positions, highlights that causes a statistically significant reduction in pain severity and some other menstrual symptoms. Physical activity and exercises are known to release endorphin hormone in the brain that raise the pain threshold and are shown to improve mood of the exercising subjects. The result of the review have revealed that performing the physical activity have reduced the symptom of primary dysmenorrhea, including pain intensity and duration of primary dysmenorrhea. So this can be safely used an alternative therapy for pain relief of dysmenorrhea and improving the quality of life of female with primary dysmenorrhea. Therefore, because of the high potential benefits of the physical activity and exercising in reducing the determinantal effect of primary dysmenorrhea symptoms, young girls and females are recommended to take part in exercise program in order to help them to decrease the negative impact of these symptoms on their academic, social, and even personal life. And the conclusion, the review identified that physical activity or exercise can significantly reduce the pain associated with the primary dysmenorrhea and the use of medications. It is our recommendation that females suffering from the primary dysmenorrhea should have an appropriate exercise program or physical activities in order to reduce the severity of pain and other symptoms. Clinicians should inform young female that physical activity may be effective treatment for primary dysmenorrhea, but there is need for high quality trial before this can be informed. The future recommendations are additional research should be done to know the effectiveness of physical activities and exercises for treatment of the primary dysmenorrhea. Research efforts are needed to better understand how physical activities can help to reduce the symptoms of the primary dysmenorrhea, which in turn will improve the quality of life of young females. Thank you. These are the references.
Yes. Yes. Any questions? Any questions to Dr. Naurup Kaur? Yes. This was your second talk, madam, by sharing your research by participating in this conference. Thank you very much.
Thank you. Thank you, sir.
Thank you very much for speaking up in this meeting and providing your perspective. Thanks for sharing your tips with us. Looking forward to meet you again next time.
Thank you.
Yes. Now would I request Dr. Meena M. Marcos from Faculty of Physiotherapy from Cairo University from Egypt to start presentation.
Hello, everyone.
Yes, sir.
Let me share my slides.
Yes, sir. You can take your own time, maybe a lot of time, sir. We are around 30 to 40 minutes ahead of the program, actual program.
Is it clear for you all?
Yes, sir.
Okay. Is it clear?
So the PPT disappeared, sir. Just you can upload once again.
Okay. Seconds. I think it's clear now. Yes?
Yes, it's fine.
Okay. First of all, thank you very much for having me with you in such a great event and a great conference for physios from all over the world. I hope my talk today will be of interest for you all and will be exciting for you. Let me first introduce myself. I am Dr. Meena Maher, musculoskeletal physiotherapist with a master's degree from Faculty of Physical Therapy in Cairo University, Egypt, the land of civilization. And I am also senior physiotherapist at Kasr Al Aini Hospitals, which is Cairo University Hospital. And I am also the creator and tutor now, and in Dr. Meena also on educational platform for musculoskeletal physiotherapists. Okay, here we are. My talk today will be about effect of chronic non-specific neck pain on the scapular muscles strength and scapular stability. Does my video clear to all?
Yes, yes.
Okay, thank you. So, I'd love always to start my lectures and my presentations with this image about info and knowledge. Many of us have great info, many of us have and learn many techniques, many ways of thinking, many protocols in treatment, but unfortunately, few or little of us have the real knowledge in clinical practice. So I'm hoping that my talk and will get the real knowledge and help us to make connections and links between the info we all have. Neck pain is a common musculoskeletal complaint with a 12-month prevalence of 30 to 50% in the adult population. And 30% of patients with neck pain will develop chronic symptoms such as limited cervical spine mobility, neck muscles weakness or inhibition, and maybe neck pain will persist for more than 6 months to be chronic in nature. And this type of pain, which is chronic or insidious neck pain, which is without a known pathological basis or a common serious pathology as the underlying cause of the complaints, which is known as non-specific, follows a clinical course that can be best classified as recurrent or episodic. characterized by periods of relative improvement, and the patient symptoms get better and the patient feels good, followed by periods of relative worsening and the patient is suffering. Our scapula plays a very important role as a link or as a bridge between two regions, which are the trunk and the arm, to transfer and increase the energy power equilibrium from the lower extremities and axial skeleton passing by the cervical spine into our upper limbs to do our daily functions of the upper limb. But because of the important but minimally bony stabilization of the scapula by the clavicle, we need to have dynamic muscle function to be the major method by which the scapula is stabilized and purposefully moved to accomplish its rules regarding its position and even its motion. And as we see here in the pictures, there are two groups of muscles, and they are the focus of the study, which are scapular retractors, middle trap, lower trap, rhomboids major and minor, and the scapular protractors, which is serratus anterior. And these two groups of muscles acting with each other like force couples to help the scapula to function well, and they are considered very important structures and necessary for normal scapular orientation and function. So, normal stability of the scapula includes the ability to maintain the normal orientation of the scapula with the arms beside the body or at rest during position and during all activities of the upper limb when the arms away from our bodies or during the function and motion of the upper limb. And here we reached to Dr. Ann Coulds in 2014 with her co-authors. They concluded that there is a strong relationship between chronic neck and shoulder pain and scapular dysfunction. Therefore, shoulder and neck pain is associated with scapular kinematic alterations as well as scapular muscle changes in strength or even motor control. That's why explained by Janda and Dr. Shirley Sarman that chronic neck pain can cause changes in the axioscapular muscles strengths, which are the protractors and retractors, and lead to altered stability of our scapula, which may in turn can create or sustain symptomatic mechanical loading of the cervical spine structures that may affect the recurrent episodes of neck pain and may be the cause or the precipitating factor to have it. And that's what we call and what we all know the link between these regions, neck, scapula, and shoulder, in the way that we all know the concept of regional interdependence. Each region is dependent on the other and they acting together. So our purpose of this study is to investigate the effect of chronic, non-specific neck pain, which means not discogenic, not facetal, not spinal stenosis, not having serious pathology on the scapular muscle strength and the scapular stability. Significance of the study. Altered activity in the axioscapular muscles and impairments in scapular orientation are considered to be important features in cervical neck pain patients. But unfortunately, scapular dynamic stability has not been investigated in patients with cervical disorders. And due to lack of research in this field, most common therapeutic guidelines intended for scapular rehab are based mainly on shoulder studies. And currently, the relevance between scapular dysfunction and neck pain is more based on clinical observation and studies of shoulder patients rather than on direct research. So here we have a gap in the research regarding this category of patients. And we hope by our study to cover this gap and participate to the body of the literature. So what this study will add to the available literature? We think that this study will add value to the available literature regarding these types of patients, that it provides an important chance to directly assess the strength of scapular muscles, protractors and retractors, and scapular stability in this category of chronic non-specific neck pain directly. And also, it will help to identify the presence or the absence of optimal scapular motion and position in the symptomatic neck pain patients, which in turn can help us to guide specific treatment options as professional clinicians. So, subjects and methods of our study are, we are going to have 66 male subjects randomized into two groups. Group A, which is experimental group with 33 patients with chronic neck pain, and Group B, which is the control group, consists of 33 normal subjects, they having no shoulder and no cervical impairment. Inclusion criteria: our subjects will be within the age of 30 to 55 years old, which is commonly called the middle-aged adults, not the young adolescents or the elderly people, because this age is thought or is supposed to be the most common category of adults to be affected by recurrent episodes of neck pain. And secondly, the neck symptoms that are persisting more than 6 months or are chronic in nature. And if any one of our participants have a non-pathological or impairment in the shoulder joint, history of head injury or spinal fractures, systematic pathology or disease, any serious psychological condition, they are all going to be excluded from our study. Our procedures: we firstly check our subjects' eligibility to participate in the study. Then all participants receive clear explanation of the study objectives and procedures. If they fit, they will have written consent, and demographic data will be collected from all the subjects regarding age, weight, height, and physical activity level. So here we have two items to be assessed: scapular strength and scapular stability. For the scapular protractor and retractor strength, we are going to use, yes, Biodex System 3 isokinetic dynamometer, which is considered the gold standard for precise and accurate muscle strength measurement. And here we have our patients. Patient is setting the arm, the tested arm, in the scapular plane, which is 30 degrees anterior to the frontal plane. And this plane is considered the functional plane of the shoulder, which provides better congruency for the bony articulation, less loads and stresses on the shoulder structures, and great and optimal orientation for rotator cuff and scapular muscles activation. His trunk are stabilized by diagonal strap, and all patients will have 5 familiarization trials to be familiar with the testing device, and all will have verbal encouragement. Testing procedure will be going to be tested 3 times at 2 linear speeds, low speed and high speed, with a resting period of 10 seconds, and then averaging will be done. Second item, which is scapular stability. we are going to use the lateral scapular slide test, LSST, which is invented and developed by Dr. Benjamin Kibler to quantitatively measure scapular stabilizer strengths by evaluating scapular symmetry as varying loads are put on the scapular musculature. And this test is commonly used in clinical practice and mentioned in multiple textbooks because the lateral scapular slide test is a simple, valid test used to assess scapular positioning and measure the simple linear displacement of the scapula on the thorax. Moreover, this test shows a high reliability for positions 1 and 2 and good to high reliability for position 3. So we can conclude that this test is a reliable test, really measures the muscles that actually working to stabilize the scapula. And here's a video where we can see and illustrate this test. I hope the voice will be clear for all.
Hi everyone.
Let me know.
The lateral scapular slide test. We are going to measure the distance between two bony landmarks, which is the spinous process.
Is the voice clear?
And the inferior angles of both scapulae on both sides. In 3 positions. Okay. Position number 1, the 0 degree of shoulder abduction, arms beside the body. So we are going to determine the angles.
We are going to test the distance
And here.
on both
So
sides
this is both inferior angles of the scapula.
from the inferior
closest
angle
spinous process
to
is spinous process of T7.
spinous process of T7, and this distance is called scapular distance to be measured.
Okay. So then we are going to measure the distance between both points on each side using our tape measure.
By tape measurement in 3 positions. This is position number 1
Here
with the arms beside the body or 0 degree shoulder abduction.
for the left side, and here for the right side. Okay. Then we are going to progress to position number 2, which is 45 degrees of shoulder abduction, patient's hands on both iliac crests. Relax. We are going to assume the position using our goniometer to assure the correct position.
Goniometer for correct angular
Surface of the acromion
positioning
process,
for position number
fix the
2,
arm parallel to subject spine,
which
we
is
remove
45 degrees
arm
of shoulder
parallel to subject
abduction.
spine.
Patient is
Ask the patient to
on
assume
both
position,
iliac
position
crests.
2. Okay.
Yes.
And here we have 45 degrees of shoulder abduction. Then again, we are going to identify the inferior angles of both scapulae.
We'll mark the inferior angles again for the second position and again measure the distance to the T7 spinous process. Yes.
Again, we are going to measure the distance between these 2 lateral points and the central point using the tape measure. And here,
Measurement for the left side and also for the
for
other
the
side.
left side. And here for the right side.
This is position number 2, which is
Okay.
45 degrees
Position
of shoulder
two.
abduction.
The last position is position number 3, which is 90 degrees of 90 degrees of shoulder abduction with full internal rotation. Again, relax. We are going to assume the position using geniometer.
Again, with geniometer, we are assuming the position of 90 degrees shoulder abduction with full internal rotation.
Abduction with full internal rotation, position 3.
Yes.
Okay. Good. And here we have 90 degrees
Of shoulder
abduction. Again, here we are going to identify both points of the inferior angles of the scapula. Here.
And again, for the last time, identify the both angles of the inferior scapulae and then measure the distance to T7 spinous process.
The distance again using tape measure here for the left side.
For the left side here.
Okay. And again for
the right one.
Right side. This distance on each side is called the scapular distance that we are going to measure on both sides and calculate the difference between two sides.
Okay. So, if any difference is present between two sides is considered a scapular instability? Actually, no, there is normal variation between side to side, but Dr. Kibler, who is inventing the test, has established 1.5 centimeter of asymmetry as the threshold of abnormal stability of the scapula in each three positions. So if we make a scapular distance at each side and find a difference 1.5 centimeter or more, we are going to conclude that this side is of scapular asymmetry or unstable scapula. So because our study is going and still under work and it is not finished yet, our results and conclusions are still pending and not known for the current moment. Thank you very much. I hope my talk was exciting and for interest for you all. That's my email. If anyone needs to be in contact, please feel free to contact us. Greetings from Egypt for you all. Available for any questions.
Yes, any questions? Any questions to Dr. Romina Marcos? Just if you have any questions, you can text in chat box. We'll be asking behalf of you, just without having any hesitation. Just you can ask the questions, because this is the webinar. Especially we are discussing on physiotherapy, physical rehabilitation, as well as sports medicine. Little bit we are covering. So without having any hesitation, just you can, apart from different regions of the world, just you can ask the questions. At present, we are having 16 participants in this event. Just you can ask the questions. Sir, it was a nice video, sir. Just you showed me everything in a single video. It was, yes, like just the video explains everything, total
yes.
subject. Yeah.
Yes.
Just this video explains the total subject. Yes.
It's a necessity to all to have this in our presentations.
Yes. Yes. Thank you very much, sir, for participating in this event.
Thank you.
Yes.
Thank you very much for you all and for all the organizers and for the nice time we'll be with you. I hope all are safe and we'll meet next time soon, inshallah.
Yes. Wish you happy Ramadan, sir, as well as we are going to start the Ramadan as well. Thank you very much, sir. Thank you very much. Looking forward to you next time. If everything goes well, we can join in physical event. Thank you very much. Now I would request Dr. Stu Bailey from Steve Bailey, acupuncture, foot knee, as well as Backlane from United Kingdom as one of the keynote speaker for this event.
Am I on?
Yes, sir.
Okay. Do you want me to make a start? Okay, so I'll just share my screen. Is
Thank
my
you
screen
very
being
much, sir, for
shared?
joining.
Or?
No,
Sorry?
sir, no. No.
All right. Do I share my screen?
Yes.
Okay, let me just do that. Just make sure. Right, here we go. Okay, hello and welcome everybody. My name is Steve Bailey. Now, this is a follow-up study in which I undertook and published in 2012. In 2012, I did a study looking at the effects of acupuncture with regards to enhancing human performance in athletes. And what I've basically done since that time, published a more current study in 2017, mainly looking at a randomized controlled trial looking at the effects of acupuncture on enhancing muscle strength. Now, the systematic review in which I did in 2012, it basically looked at enhancing DOMS, reducing DOMS, also enhancing muscle strength, and in addition to reducing heart rate and removal of lactates. Now, with regards to enhancing muscle strength, there was conflicting findings with regards to that, whereas 2 studies found a significant effect for acupuncture and 2 studies found no significant difference between that and the sham acupuncture group. So since that time, I'm not aware of any other systematic review or meta-analysis that's actually been undertaken. So this is a study that I've just recently completed and it's in the process of being published. That I'll actually be presenting to you today. Now, so the primary aim of the study is to investigate and summarize available literature on the effect of acupuncture on enhancing muscle strength in human. Now, the methodology in itself, we did do a literature search right from inception right through to 2020 on electronic database. All the risk of bias was actually undertaken by myself and a colleague. Any kind of discrepancy that was presented, then we met and came to a mutual agreement with regards to each of the studies. Now, the Pedro scale was actually used to assess the methodological quality of each of the studies, whereas the standard for reporting intervention in clinical trials of acupuncture, or better known as the stricter, was used to assess the quality of the acupuncture intervention itself. The study is actually presented using the PRISMA guideline. So if we look at the inclusion criteria, primarily RCTs was actually used that assessed acupuncture on enhancing muscle strength, mainly in humans. We didn't actually include any animal studies within this. Any papers was actually sought, whether it was in English or any other language, as long as we could get it translated into English, then those papers were actually used. We did use other papers were actually excluded, mainly that wasn't a randomized controlled trial or anything such as a single case study, and particularly where it didn't actually involve humans in that respect. Again, the points that was actually used had to be classified as classical acupuncture points, otherwise they was actually excluded from the study. Now, total of 361 papers initially on the initial search was actually located. What we then did was to go through those papers. Any duplications were then removed and excluded. Now, that left us in total with about 24 papers, which gave us the full text article. Now, from those 24, a further seven was excluded. 2 was due to the being protocol. 2 was also studies on animals, and 3 did not classify the points as classical acupuncture points. So overall, that left us with 7 studies in which to use for our systematic review. Now, the study characteristics, papers was published from 2006 right through to 2019. Overall, there was approximately 653 participants, age range between 17 and 85. Now, within each of the groups or sample size was 17 to 73, with on average, majority of studies had 30 participants in each of the study. Now, 10 of the studies used a single treatment session, whereas 7 of the studies used multiple treatment sessions, which was over either 2 days or as much as 8 weeks. Now, the key thing is not all studies actually gave an indication as to the ratio between male and female. 6 studies in total only didn't give any indication with regards to gender. So overall, there was at least a minimum of 215 male and 130 female. But that was the only, information which we got from that. Now, 14 studies used healthy subjects. 1 study in particular used post-stroke patients. Another study used post-stroke patients and healthy patients. And another one used patients suffering with sarcopenia. Now, overall, 7 studies compared the effects of acupuncture with control. 9 studies compared the effects of acupuncture with a sham group and a control group, whereas 1 study only evaluated it and compared it with a sham group in itself. Now, the overall drawback, once looking at some of these particular studies, was the quality. And on average, where they actually scored high, the majority of the study did score high. 1 study scored moderate. So if you're looking at the scoring on the Pedro, 10 is the highest you could actually score. 1 study in particular scored 9. Otherwise, the average scoring was between 6 and 7. 1 study scored moderate, which is 5, and 2 studies scored low, which they both scored 3 on the Pedro scale. Now, one of the main drawbacks was the actual blinding of participants, but once you start to look at acupuncture studies, generally, it's not easy to blind the therapist or the actual participant when it comes to acupuncture. 3 studies did report blinding of subjects. Normally, if you blind a subject, you would need to use some kind of assessment tool to determine as to how effective that blinding was, in which case these 3 studies didn't report any kind of assessment to determine the effectiveness of the actual blinding itself. 2 studies blinded the therapist and 7 studies blinded the assessor from subject allocation. Now, the actual acupuncture intervention, one of the key things is if you're not choosing the right points or in the right location, straight away that can lead to treatment failure pretty much straight away. And if you look at the overall, none of the studies actually used the stricter. The main issue was choice of points. And obviously, if you're not choosing the appropriate points, then again, that can lead to treatment failure. So one of the key things that we were actually finding in the majority of studies, the main studies did not choose points that had a direct effect or known points to have a direct effect on enhancing muscle strength. Also, the justification for the choice of points was pretty poor in majority of studies. So if we was to look also is Fregoso, they actually chose 1 point, so which was large intestine 11, and they compared it to pericardium 6. Again, these 2 points are not known points to enhance muscle strength. And again, if you're actually going to apply an acupuncture treatment, normally it is more than 1 point. And if you look at the key studies, which will demonstrate to you, anything less than 2 acupuncture points is not going to have a main effect. So it wasn't surprising in that particular study, there was no significant effect on in terms of acupuncture. So frequency, number of treatment session is also important. From the study in which we conducted, published in 2012, from that systematic review, it did demonstrate that the studies that had several treatments over a certain time period was far more effective than those studies that only applied a single treatment session. So that was one of the other key things. The majority of studies in this only used a single treatment session. If you look at the study by Zane and De Souza, chose points based on the location. So again, it wasn't choice of points based on the function, it was more based on the location. Hubska chose points based on their earlier study. They did make some finer changes, but however, their earlier study actually failed in demonstrating enhancement in muscle strength. So you would have thought that they would come up with a completely new set of points. Damasceno analysed the effects of tonification points. Again, tonification points I've not seen any literature to demonstrate that these are effective points on enhancing muscle strength. Tough chose points based on segmental innovation. But however, again, the sham points was also chosen and fell into the same segmental innovation as the classical acupuncture points. And the classical acupuncture points that was in the segmental innovation, again, was not known points to enhance muscle strength. So therefore, again, it was no surprise that there was no significant difference between groups. So overall, the other key thing that was actually noted within these studies was the delayed effect of acupuncture was not taken into consideration. And majority of studies actually applied acupuncture and assessed immediately following the acupuncture intervention. Now, if you look at several studies, it has been demonstrated that acupuncture, there's a delay in its effect, and that can be anything between 1 and 24 hours, as been demonstrated by Price. Same again in our early systematic review, what we basically found that it could be anything up to 72 hours before acupuncture actually peaked in its effect, and any assessment that was taken immediately after was not necessarily an effective outcome. So again, those studies have actually demonstrated that acupuncture is not always going to demonstrate an effect immediately when assessed immediately after. Now, the other key problem that was actually presented is the choice of sham, the actual choice of sham actual points. Now, two studies, higher ranking studies in this systematic review, used electromyostimulation as a sham. Now, as a sham intervention, obviously there wasn't aware that electromyostimulation is a form of enhancing muscle strength, and it is used quite frequently with regards to rehabilitation of muscles. And it has been demonstrated that an 8-week program can increase the vastus medialis, by as much as 39%, and the vastus lateralis as much as 69% increase over an 8-week time period. So again, in those particular studies by by Huang and also by Zhou 2012, demonstrated that there was no significant difference between the acupuncture intervention and the group that received electromyostimulation, purely because they're using a sham intervention that has been demonstrated to produce enhancement in muscle strength. Not just that, the key importance is also where you put those sham points. So again, it has been demonstrated those sham points in which they used in those two particular studies that was mentioned was actually over the nerve trunk, and also it was also over the belly of the nerve. So it was over the belly of the tibialis anterior, and those are the muscles that's going to assess ankle dorsiflexion, and also over the deep peroneal nerve. So in that respect, stimulation on those is going to automatically enhance muscle strength. So therefore, it's not what you would classify as a true sham. The other key thing was one study in particular, Damasceno. They started off with 53 subjects, ended up with 26. So in other words, they had more than half of their subjects was lost to follow-up. So again, in this study, it wasn't surprising that there was no significant difference between groups. And it is, wise that if you are going to use some kind of protocol, you do carry out a pilot study first, one to assess your sham acupuncture intervention, to see if it's worthy of actual use, and also to ensure that your study isn't going to have a high loss to follow up. So if we look at the overall results and taking some of those key factors into consideration, overall 16 studies that compared the effect of acupuncture with a control group showed that 11 of the studies found that acupuncture was significantly more effective than the actual control group in enhancing muscle strength. 10 studies that compared the effect of acupuncture with a sham acupuncture. 5 studies found that acupuncture was significantly more effective than the actual sham group. And 5 studies found that there was no significant difference between the acupuncture and the sham intervention. But just going back to what I was saying beforehand, you do have to bear in mind that some of the sham intervention wasn't what you would classify as having an inert effect. Some of those sham intervention was having known effect on acupuncture, on enhancing muscle strength. So they wouldn't be classified as a true sham in one respect. So if we was to overall look at the studies that actually enhance muscle strength and look at the area in which these studies was actually conducted. So if we look at the effect on the elbow flexor strength, overall there was no significant difference in both of these studies between the acupuncture and also the sham and control groups. Both of these studies scored quite well on the Pedro, scored 7 and scored 8. But again, if you look at the choice of points, the not known points which have been put out there to enhance muscle strength. Same again, you've got the one by Zane and also Tough. Going back to the one by Tough, Tough scored 5, which is an average on the Pedro scale. But again, not particularly chose points that are known to enhance muscle strength. And again, these points were chosen purely on their nerve innervation and the locality of the muscles that was going to be assessed. But however, the sham acupuncture points was also in the same nerve innervation. So again, no surprise, there's no significant difference between groups. Once we start to look at the hand grip strength, just coming back to what I mentioned with regards to Damasceno, their study started off with 53 subjects, finished off with 26 subjects. So there was a high dropout rate in this particular study. So again, no surprises, no significant difference between groups. The other study by Silveiro Lopez, better choice of points. So these are known points which are being put forward to enhance muscle strength on some of the points. Even though it was a single session, there was a significant difference. So overall findings for this is there's mixed results with regards to that. If we look at the effects of acupuncture on trapezius, only one study was actually found with regards to the trapezius, scored high on the Pedro scale, but overall, looking at the choice of points, again, even though there was significant difference between the control and the acupuncture intervention, once I take a look at the actual points, these wouldn't be points which I would have recommended personally. And if you look at key research that's been undertaken, where they've given good justification of the points, these are not known points to enhance muscle strength. So there are 2 key missing points missing from that group, which would have made a better result. Now, if we take a look at the effect on the rectus femoris, so once we start to look at the lower limb, then we start to see much better choice of points, much better overall outcome. So overall, with regards to these studies, only one study scored low, but that was by So, which only scored 3. Otherwise, the remaining studies scored high. Same again, what we basically found was overall significant difference in favor of acupuncture. The only one that didn't show a significant difference was that one by Hubsker. Hubsker found acupuncture was significantly more effective than the control group, where acupuncture group, there was an 8% increase, where the control group, there was only a 3% increase. However, the sham only had a 5% increase. And so the difference between 8% and 5% was not significant. So therefore, no significant difference between the sham group, but however, significant difference between the acupuncture and the control group. But overall, acupuncture did fare more effective with regards to enhancing strength in the rectus femoris. Same again, once we start to look at ankle plantarflexion, ankle dorsiflexion, overall mixed views or findings here. 3 studies showed a clear improvement in muscle strength in the acupuncture intervention. However, 3 studies found no significant difference between the group. But just going back to what I was saying earlier, if you look at the study by Zhou, 2012, and also Huang in 2015, those 2 studies used electrical stimulation over the muscle belly and over the actual nerve trunk of the ankle dorsiflexors. So they wouldn't be what you classify as a sham intervention. But if you're looking at the electro and the manual acupuncture against the other groups, they did fare significantly more effective. So if a better choice of sham was chosen, then these outcomes may well have been different. But overall, what we can say from the studies in which we've actually presented is that there's mixed views with regards to the actual acupuncture intervention. Overall, again, better choice of points within these particular studies. So if we look at the overall conclusion with regards to these findings, the overall findings indicate that there is stronger evidence that acupuncture is more effective than the actual control. But there's conflicting evidence with regards to acupuncture is more effective than the sham acupuncture enhancing muscle strength. So therefore, further studies are actually required with better evidence-based justification for 1, the choice of acupuncture points, and 2, the better choice of sham points would need to be used, and also in addition with regards to the stricter. So they're the key drawbacks with regards to that. So thank you for listening. I'm not sure if anybody's got any questions. I'm more than happy to answer any questions that anybody may well present with.
Any questions?
I'd like to ask here.
Yeah?
Yes.
Can I?
Yes, sir.
Okay. Thanks, Steve, for this nice presentation and clear study.
You're
but
welcome.
regarding the acupuncture,
Yeah.
you have mentioned in response to the control group, the acupuncture has a strong evidence that it enhances muscle strength.
Yeah.
Can we use it in different conditions or clinical problems that we face, or in just some conditions?
Well, I use it. I use it on a number of occasions within clinical conditions. So I use it partly as a rehabilitation. So if you look at the different studies, as I say, some of them's been used in post-stroke patients, particularly rehabilitation. The sooner you start with your post-stroke patients, the better. Again, I've used it on some of the elderlies during rehabilitation. And same again, I use it a lot with athletes. So with regards to athletes, not necessarily on an injury basis, I use it on a performance basis with many of my athletes. So either I'll use it as part of their rehabilitation, or I'll use it where they're striving to either get onto a team, or they're striving to improve their running time, cycling time, or anything such as that. So that's pretty much another way in which it can actually be used. So there's a number of methods, applications in which it can actually be applied.
Okay. Do you use it alone or in combination with other techniques and rehabilitation protocols?
Well, to be perfectly honest with you, as I was trying to point out beforehand, if you are using it on athletes, and you're trying to increase athletic performance, now athletic performance isn't purely down to muscle strength. You have got to look at the whole cardiorespiratory aspects of things as well. So in one respect, you've got to look at the circulation. Another respect, you've got to look at the lung capacity. And then you've also got to combine that with muscle strength. So I only use a set number of points, and I find utilizing it that way, you are going to get a far better outcome from your athletes if you're actually looking at utilizing it on that basis.
Okay, thanks a lot, Zain.
Okay.
Yes.
Anybody
Any further
else?
questions?
Any other questions?
I, I think no questions, sir. I think.
Okay, you're welcome. Thank you, everybody, for listening.
Any questions? Any questions further?
So, do you want me to stop
Just,
sharing?
if you have any questions, yes. If you have any questions, you can ask. You can text in chat box. We'll be asking behalf of you without having any hesitation, because it's a webinar that we are discussing about physiotherapy during this pandemic period. Any questions? It was a great, sir. Actually, I'll be look after your. You'll be only in LinkedIn, sir. A live. This is a. I just. I'm be looking in front of you. It's a grateful to me.
Welcome.
Yes. Thank you very much, sir, for participating in this event. On behalf of organizing committee member of Physiotherapy Congress 2021, we want thank you for your insight presentation. Looking forward to meet you again next time in physical event if everything goes well. Yes. Just we invite the other speaker is Dr. Now we invite Dr. Azan Ulas, US from Department of Sports Medicine from Near East University from Cyprus to start the presentation. Actually, we are 30 minutes ahead of the program, so that's why they cannot be joined the program. Just we are running around 30 to 40 minutes ahead of the program. Dear participants, meanwhile, just we will take around 10 minutes break and rejoin the event again. Now we'll have 10 minutes break and join the event sharp by 5:50 according to IST timings. Sorry, 4:50 according to IST timings. Yes, Prof. Shall we start the program? Yes. Now I request Dr. Kerner Lazzolo from Faculty of Health Science from University of Pex from Hungary to start the presentation.
Okay, I'm here.
Yes,
I don't know. Do you hear me?
Yes, sir.
Okay, thank you. Moment.
Just video have a lot of time, sir. You can take your own time.
Okay, dear ladies and gentlemen, you hear me?
Yes, sir.
Okay, I'm Laszlo Kerner from Hungary, Central Europe. I'm the doctoral student of Science University of Pécs, Faculty of Health Science. I'm going to speak about impact of online physical education among 8th grade students during COVID-18 spring lockdown in my oral presentation. Introduction. The SARS-CoV-2 virus, which causes a disease called COVID-18, has completely changed the daily behavior of people worldwide in 2020, including young people. The Hungarian government declared a state of emergency on March 11, 2020, and as a result, educational institutions were instructed to suspend personal lessons and switch to e-learning online lessons. The global health crisis has resulted in high levels of inactivity, with several studies showing the negative impact of physical inactivity on health status. During the COVID-18 epidemic, decreased levels of physical activity were detected among young people in higher education, highlighting the need to promote physical active lifestyle in the face of epidemic-related restrictions from March et al. 2020. In the early COVID-19 period, children spend their leisure time overwhelmingly in physical activity instead of exercising. Girls and older children generally spend more time in these active behaviors than boys and younger children. It's from Watson et al. 2020. Measures that result in isolation to protect public health are changing the physical activity habits of the population in a way that is determinant to health. It's from Amar et al. 2020. Classroom physical activity can positively affect children's learning outcomes. It's from Watson et al. 2017. Decreased physical activity has a negative impact on people's health, including the risk of cardiovascular disease. So the beneficial effects of physical activity are remarkable, not only in people with chronic illness, but also in healthy young and adult individuals. It's from H et al. 2020. Short-term changes in physical activity and sedentary lifestyle have been demonstrated in the COVID-18 response, which may lead to obesity, the development of diabetes and an increased risk of cardiovascular disease in children. It's from Bantam 2020. Our research focuses on the acute psychological effects of online physical education lessons and physical exercise activities during the epidemic from a positive psychological approach. The aim of our research was to explore the different effect of online exercise activity on. The following slides are the material and methods. Okay. The study was performed on 8th grade students of primary school in a small town in Western Hungary, Central Europe, during the quarantine period 2020 spring. Participation on the research was undertaken by 66 students aged 14, 15, of which 19 and is equals 19 had results that could be used in all respects. Students' results were treated anonymously after coding. Figure 1 shows students received a detailed description of the curriculum via email and also in the school's central messaging system, which included the 3-week training plan itself, shows the figure 2. The 5-day weekly exercise activity consisted of a combination of running, cycling, and circle training. The motto tasks were determined on the basics of the protocol already known to the children and in accordance with the principle of gradation, that is the extent of the loads increase day by day, week by week. And the last of the 3rd week was to complete the Cooper test, 12 minutes persistent running. During the workouts, the kids used the Running Up by Runtastic mobile application developed by Adidas, which provided an opportunity to really track the tasks. Students were also asked to complete a short questionnaire immediately before and after the physical activities. The 19 students completed the pre- and post questionnaires a total of 86 times. In addition to demographic and exercise questions, we also used 2 psychometric scales. The widely used Rosenberg self-esteem scale is one of the most popular methods for measuring global self-esteem, and its reliability and validity are supported by numerous studies. The following slides contain the 3rd and 4th figures. Figure 3 shows participants completed the Hungarian version of the Rosenberg self-esteem scale, RSES Rosenberg 1965, and the positive effect, negative effects, Shadal, Panas, Watson, and Intelligent 1988. During the 3-week assignment, show the figure 4. Well, here is the results slides. Okay, some of the students included in the study reported lack of equipment, low battery of the phone used to perform the tasks, loss of internet connection, and other unexpected consequences that significantly reduced the number of items. N is equals 19. Here can be seen the figure 5 in this slide. Figure 5 shows the means and the standard deviations of Rosenberg self-assessment of the measurement before and after physical activity. The measuring range of the scale varies from 10 to 40 points. The values of the Rosenberg self-assessment scale showed no difference in measurements before and after physical activity. You can see on the chart there is no significant here. Okay. Just following the next results slide, figure 6 shows the mean and standard deviation of positive and negative effectivity, where after exercise activity, students were able to identify significantly more positive emotional states in themselves. They felt better. According to the results of the paired t-test with the analysis of the whole sample, the values after exercise showed a significant difference in the positive subscale of PANAS. You can see T is equals minus 1.935. Different is equals 85, P is less than 0.05. Okay. After physical activity, students were able to identify significant more positive emotional states in themselves. Figure 7 shows this result was also valid results for the girl sample at the trend level, but as an unexpected results according to the boys' PANAS negative subscale, the frequency of experiencing negative effect after exercise activity increased. You can see T is equals minus 2.348. Difference equals 35. P is less than 0.025. These self-assessments showed no differences in the study interval. Okay. The results characteristic of the whole sample was also valid for the girls sample at the trend level. We can state that students felt better after physical activity, shows the figure 8 in this slide. Okay. Ladies and gentlemen, we arrived to discuss the conclusions. The results of our suggest that 3-week online physical education lesson related activities in the study age group had no significant effect on self-esteem due to the fact that self-esteem is a relatively stable trait type variable. The conflicting results of positive or negative effect experienced during exercise activities make probable that the effect varies as a function of exercise intensity. The development of positive or negative effect can be characterized by an inverse U-shaped relationship in untrained individuals in line with the underlying metabolic processes It's from Mekakis et al. 2008. Okay, exercise with optimal intensity generates positive effects, and exercise below and above optimal is associated with experiencing negative effect as it appeared in our research. In trained individuals, both optimal and higher intensity are associated with positive effect. It's from Reed and Vance 2006. Based on the results of the research, we can conclude that physical activity as a particularly positive stimulus for students' psychological processes can only be considered by considering fitness level and regulating intensity. Short recommendation. My suggestion in the future is the following. The research needs to be extended to a larger number of items, and maybe that individual load coefficients need to be adjusted according to age-specific characteristic. Okay, here can be found the recent publications. Here also the publications, and yes. And thank you for attention. I would like to thank my supervisor and of course the conference organizers for hosting my presentation. Thank you very much once again.
Yes. Any questions? Any questions to Dr. Kerner? Yes, thank you very much, sir, for participating in this event. On behalf of organizing committee members of Physiotherapy Congress 2021, we want to thank you for your excellent presentation. Thanks for sharing your tips with us. Looking forward to meet you again next time.
Thank you so much.
Thank you so much, sir. Yes, according to the scientific program, Dr. Hazanopoulos Huvezi from Near East University from Cyprus has to join the event, but there is no response from Dr. as well as Dr. Vivan. So we ask. So we'll be going with the video presentation of Dr. Adam Laki from Institute of Sports Sciences from Ethiopia's Laureate University from Hungary. Just will be playing the video presentation. It's a video which is covering the subject title like balance skill examination in children with genus vulgum from Physis planus. Meanwhile, other speakers will be joining the event and they're delivering their talk. Hope you understand, support this conference.
the audience of the Congress, and thank you for the possibility to share my work with you. Let me introduce myself. I am Adam Lucky from Hungary. I am PhD Fellow in Eötvös Loránd University, Faculty of Education and Psychology, Institute of Sport Sciences. My specialty is physiotherapy education, diagnosis, and rehabilitation of pediatric orthopedical deformities. Beside of this, I am the fitness and rehabilitation coach of Falco Basketball Club. This is the only Champions League club in Hungary. The title of our research is Balance Skill Examination in Children with Janovágó and Pesplanus. Here I would like to mention my colleagues, Monika Szigeti, Katalin Nagyváradi, and Ferenci Ház, and render thanks for their help. I would like to continue my presentation with the research. What about the theoretical background of our research? Sedentary lifestyle is specific for the upgrowing generation, and it has a negative effect for the musculoskeletal system. Research is reported about the correlation between obesity and fat and food deformities. Just as food deformities can influence balance skills negatively, and it can increase the chance of sport injuries. The key point is the examination of the lower extremities among pupils and students. The goal of the research is to investigate the body composition and balance skills in the group of students with Janovágó, in English in knee, and Pesplanus, in English flat foot. According to the previously mentioned statements, we asked the question: what kind of differences can be observed in balance skills and its components among children with foot deformities? How can flat foot influence the static balance skill, the area of the center of gravity, and the velocity of the amplitude? We can ask the same questions in case of in-knee deformity. Besides the balance skill, we were curious about the correlation between obesity and deformities in this small group. Let's continue with the methodology of the research. We worked with 18 male children in our research. In average, they were 12.5 plus minus half years old. We formed 3 groups. The first case group consisted of 5 children with in-knee, while in the second case group there were 6 participants with flat foot. In the control group, the 7 children did not have any deformities. We applied 2 measurements in our examination: static balance skills on one leg, known as Flamingo test, and PJS type power plate, and body composition measurement with InBody 720 equipment. The children were asked to do a general warm-up for 8 minutes before the examination. Then they took off their shoes and they had the possibility to try out the balance test once with both legs. During the balance test, they were asked to stand on one leg on the power plate while trying to keep a plus sign in the center on a coordination system, which was projected on the wall in front of the participants. They were able to move the plus sign with their balance. The balance test lasted for 30 seconds per leg. Every student began the test with the dominant leg. It is very important to mention that the power plate measures the velocity R rate. It means the transposition speed of the center of gravity on the R axis. 95% of the measured data are in this range. The velocity mean R rate shows the average speed of the center of gravity movement along the r-axis in millimeter per second. Furthermore, it shows the speed of the movement along the radius. After the balance test, the next examination was the body composition test. We measured two body composition with InBody 720 bioelectric impedance analyzer. The device contains two stainless steel footrest electrodes with two handles which join foot-foot, hand-hand, and hand-foot. This information facilitates a tetrapolar 8-pointed touching. We examined the following data with the help of InBody 720 equipment: weight in kilogram, body fat in percent, amount of muscle in kilogram, body muscle in percent, amount of fat on the leg in kilogram, body fat of the leg in percent, weight of the leg in kilogram. We used statistical for Windows 13.2 program for the analysis of the data. After the methodology, let me continue with the results of the study. The average body composition rates among the examined participants, according to the three groups, are the following. Average height of the healthy students is 169 centimeters. Their weight is 55.4 kilograms. Their body fat 11.2% and body muscle is 49%. Students with flat foot were 161.8 centimeters tall in average. Their average weight was 44.6 kilograms, with 10.7% body fat and 48.1% body muscle. Children with INNI were 170 centimeters tall average. Body weight was 69.4 kilograms, with body fat 25.2% and body muscle 41.4%. What about the balance scale results? On the first picture, we can see the movement of the center of gravity of a student with flat foot in comparison with a healthy child during the flamingo test. We haven't found significant difference between the two groups in the area of the center of gravity movement. On the second picture, we can see the comparison of velocity mean R value between healthy children and children with flat foot. The difference between the speed of the center of gravity movement is clearly visible if we compare the two groups. The speed of the amplitude and the corrugation were significantly higher among children with flat foot in comparison with the healthy group. On the third picture, we can see the comparison of velocity mean R value between healthy children and children with INNI. Children with INNI have a significantly lower center of gravity movement speed in comparison with the healthy students. We can identify from the two pictures that there is a significant difference in the center of gravity movement speed between children with flat foot and INNI. The average speed was significantly higher among children with pes planus. In conclusion, we can determine the following. In body composition, we found significant differences in two comparisons, Genovagum and control group, Genovagum and pes planus group. In body fat, Genovagum 25.2 plus minus 3.2%, pes planus 10.7 plus minus 1.8%, control 11.2 plus minus 2.8%. Children with INNI have a 2 times higher body fat rate than healthy children or children with flat foot. In this point, I would like to mention the body muscle of children with INNI is lower, but not significantly. In balance scale, we found the following. Velocity mean R in millimeter per second. Genovagum 67.7 plus minus 4.8 millimeter per second. Pes planus 93.3 plus minus 7.1 millimeter per second. Control group 80.8 plus minus 6.6 millimeter per second. As a summary, we can say that children with flat foot were faster and children with INNI were slower in center of gravity movement than their healthy mates. In the end, sum up our research. In spite of the low number of items, we can determine the body composition results. The children with INNI stand closer to obesity, and there is a remarkable difference in balance skills, which fact asks us to further research. Flat foot and INNI are influencing squarely the static balance skill, namely the movement speed of the center of gravity. The movement speed of the center of gravity among our participants shows that children with flat foot has a higher speed of amplitude and corrugation in comparison with children without deformity, while students with INNI have slower speed results on the test. The two deformity influence the movement speed of the center of gravity in opposite way. We suppose that reason of the significant difference is the proprioception, the disparity of the nerve-muscle relationship. Posture changes according to the deformity and static discrepancies. The hypothesis should be examined further according to our opinion. It is clear that the limitation of our research is the small number of items. That's why we would like to extend the study with children with other orthopedic deformities such as scoliosis, kyphosis, and pollex. Beside of these, it will be interesting to examine the dynamic balance skill of children with several orthopedic deformities. Thank you for your attention. If someone has questions about the presentation, I will answer via email. I hope you enjoyed my presentation. Have a great day.
Yes, doctor. This is the video presentation from Dr. Adam Taki from Florent University from Hungary. So next we invite Dr. Vivian Mushawar from Department of Medicine and Surgery for Motor Aptive Rehabilitation Technology from University of Alberta from Canada to start presentation as is one of the keynote presentation for this event.
Can you please allow me to share my slides?
Yes, yeah, just yeah. Yes, madam, you can start your.
All right. Thank you very much for the organizers for inviting me to give this talk today. It's a great pleasure to be with you. The overall goal of the work in my lab is to develop interventions that would improve function after neural injury or disease. And the focus of today's talk is on improving walking capacity in persons experiencing spinal cord injury. And the primary message that I would like to import today is that engaging the arms simultaneously with the legs in a rhythmic, active, and load-bearing activity-based therapy can improve walking capacity after spinal cord injury more than what could be achieved by engaging the legs alone. So just a quick overview of the work in my lab. As I mentioned, we focus on restoring function, and the primary drive is on restoring mobility, especially after a spinal cord injury, or especially walking after spinal cord injury. But we also develop wearable technologies to prevent secondary conditions such as pressure injuries using an intervention we developed a few years ago called Smarty Pants, and deep vein thrombosis through a recent intervention called the SOC. Now, turning our attention to walking for the rest of the talk, our goal for decades has been to harness the networks in the spinal cord for restoring functional mobility after severe spinal cord injury. And substantial effort in our lab has been focused on the lumbar enlargement, which contains a large proportion of the neural networks involved in locomotion. And for conditions of severe spinal cord injury, we focused on reactivating the networks within this region through a micro implant. And the micro implant allows us to deliver intraspinal microstimulation to activate elements of the locomotor networks in the lumbar region. And to date, this work has been very successful in animal models and has led to very impressive functional overground walking. And we are now preparing the implant for first-in-human testing. Now, in persons with less severe spinal cord injury or experiencing other neurological conditions, such as stroke or multiple sclerosis, we proposed engaging the arms along with the legs in an activity-based therapy paradigm for improving walking to allow for the engagement of the spinal networks throughout the cord. And we strongly believe that this engagement is what is needed for effective walking. Now, there's plenty of evidence that supports that the arms are important for walking. We already know that the arms swing in coordination with the legs during walking, and the swinging is not the result of the arms behaving as passive mechanical appendages. Instead, arm swing is neurally driven, and the neural drive to the arms is coordinated with the drive to the legs. Now, this knowledge has been around for many years, and a number of investigators suggested that the arms can modulate the motor output of the legs. However, the arms have not to date been systematically involved in activity-based therapy for improving walking, and most therapies, as you can see in these pictures, focus primarily on the legs, and often only on the legs. So we wanted to investigate whether engaging the arms simultaneously with the legs does lead to functional improvements in walking, even after chronic spinal cord injury. And we asked 3 questions. Would coordinated activation of the arms and legs improve walking capacity? Would it enhance descending drive from the brain to the legs? And would it enhance the cervical lumbar connectivity in the spinal cord, or would it enhance propriospinal modulation? And for today, I will show you some highlights of our findings in association with these questions. Now, to deliver the intervention, we decided to use simultaneous arm and leg cycling as an activity-based therapy that is efficient in terms of staff utilization. And this intervention allows coordinated rhythmic activation of the arms and legs. And we applied electrical stimulation to the legs to assist with the generation of the movement, as well as provide a phasic sensory input to the spinal cord during the movements. Now, for the study, we recruited 15 participants experiencing chronic incomplete spinal cord injury, classified as AIS C and D. And of course, everyone knows this means that the participants had some connections retained between the brain and spinal cord below the level of injury, but still had substantial disruptions in their walking ability. Injury level was C4 to T10 for all participants except for one person who had a C3 injury. And the participants were divided in two groups, as you see over here. Both groups had similar characteristics. The first group performed arm and leg cycling only, while the second group performed legs only cycling. Now, training was for 1 hour per day, 5 days a week for 12 weeks. And in both groups, electrical stimulation was applied to the same muscles of the legs. And although the primary outcome measure was walking speed, we performed extensive clinical, biomechanical, and electrophysiological assessments before, during, and after the cycling intervention. And of course, electrical stimulation was not used during these assessments. Now, over the next few slides, I'll show you some highlights of the findings. I'll start with the primary outcome measure, which was walking speed. For this, we used, as many of you would know, the validated 10-meter walking test. And of course, this test, in this test, we asked the person to walk in a straight line for 10 meters, and they are instructed to walk as fast as they are comfortable to. And what you see in this figure on the x-axis is the time in weeks since the beginning of training, and on the y-axis is the percent change in speed over the weeks of training relative to each person's walking speed prior to the initiation of training. Now, both groups of participants had similar pre-training walking speeds, as you could see over here. Now, what you see in the figure is that both groups improved their walking speed over the course of training. And at week 12, or the end of training, each group showed significant improvements in their walking speed relative to their baseline levels. But the increase in walking speed was significantly larger in the arm and leg cycling group relative to the legs only cycling group. And the absolute mean increase in walking speed is shown over here for both groups. And as you can see, the absolute increase was nearly 3 times larger in the arm and leg group relative to the legs only group. Now, we saw also significant increases in walking distance based on the 6-minute walking test. And here again, both groups significantly increased their walking distance at the end of training relative to the pre-training levels. We compared the results of the study to published work involving gait-specific locomotor training, such as body weight supported treadmill training or other overground walking training for people with incomplete spinal cord injury. And the dashed line over here shows the average across the studies that had training protocols similar to ours. And the numbers in the bars represent the sample size for each study. Now, it's intriguing to see that leg cycling in our group can improve walking speed to a similar extent seen with other gait-specific training paradigms. But the arm and leg cycling group appears to improve walking at least twice more. Now, we also see similar comparisons for walking speed, where again, leg cycling is similar to other gait-specific training, and arm and leg cycling is at least twice as large in its improvements in walking distance. So there are 2 takeaway points to note here. Cycling training translates to improvements in walking, and simultaneous arm and leg cycling results in twice the improvements in walking ability. So I'm going to show you here some videos to show you what the improvements in walking look like. These videos here show a participant in the legs only cycling group before on the left and post training on the right. And what you can see is that walking speed has significantly improved, and the participant is having less trouble lifting her legs and propelling herself forward. Now, these videos show a participant in the arm and leg cycling group before and after training. Before training, you can see that the participant is hunched over, is looking down and walking slowly, and is having to make a lot of effort to swing his legs forward. After training, he's standing up straight. He no longer is needing to look at his feet during walking. He has improved sensation that allows him to know where his legs are in space, and his spasticity is reduced, and he's able to walk much faster relative to pre-training. So the question became, what is contributing to the improvements in walking ability? And we wanted to see the effect of training on corticospinal excitability. Now, as many of you know, we can use transcranial magnetic stimulation, or TMS, to assess corticospinal excitability, where we stimulate different regions of the motor cortex and we record the motor evoked potential, as you can see over here. This is now a typical motor evoked potential trace, and on these traces, we measure the peak to peak amplitude of the motor evoked potential and see how it changes with training. And what we usually do is obtain measures of the motor evoked potential, as you can see here, for each study participant before and after training. And what you see is how the peak to peak amplitude of the motor evoked potential changes as a function of TMS, or transcranial magnetic stimulation intensity, before training and after training. And what we do is we quantify the change in the maximal MEP obtained before training and after training. We focused our motor evoked potential measurements on the tibialis anterior muscle. And we found that the maximal motor evoked potential amplitude was significantly increased in the arm and leg group relative to pre-training levels. This increase was not significant in the legs only cycling group. So far, we have addressed two of the questions we set out to answer. We found that simultaneous coordinated activation of the arms along with the legs in a rhythmic activity-based therapy leads to larger improvements in walking capacity than achieved by activation of the legs only. And two, we found that the coordinated activation of the arms and legs result in enhancements in descending drive. So the next question became, what are the effects of training on propriospinal regulation, and particularly on the cervical-lumbar coupling in the spinal cord? Now, this is a difficult question to address directly in humans without using invasive methods. But there is an indirect way that we use to evaluate the cervical-lumbar connectivity. And that is, this way involved eliciting a reflex in the legs and then having the arms do some sort of activity, either, for example, cycling or holding statically. And we looked at the effect of this activity in the arms on the evoked reflex. So what we specifically did is we evoked an H reflex in the soleus muscle by electrically stimulating the tibial nerve, and we monitored what happens to the amplitude of this H reflex when the arms were held static or when they were cycling. Now, before we get into what we found out, let's make sure that we all remember what the H reflex is. Now, of course, you already know that the H reflex is the electrical analog to the stretch reflex. Now, you commonly evoke a stretch reflex by tapping the tendon of the muscle. With the H reflex, you basically evoke a stretch reflex by electrically stimulating the nerve innervating the muscle of interest. And in this case, we evoked an H reflex by stimulating the tibial nerve. And what happens when you stimulate the nerve is you activate the axons of the alpha motor neurons directly and make the muscle evoke a contraction, and this is called the M wave, but you also activate the 1A afferents that are in the nerve. And these 1A afferents travel to the spinal cord where they activate the alpha motor neurons. And this excitation wave is called the H reflex. So what you see over here is a typical H reflex. You see the stimulus artifact over here. You see the M wave resulting from the direct activation of the alpha motor neurons or the axons of these neurons. And you see the H reflex, which is resulting from the activation of the 1A afferents. And throughout an experiment, what you do is you hold the background muscle activity and the M wave constant, and you monitor what happens to the H reflex as a result of your experimental paradigms. So now back to our experimental setup. And as I said, to understand the connectivity between the cervical and lumbar regions of the spinal cord, we elicited the H reflex in the soleus muscle by stimulating the tibial nerve, while we had the participants cycle with their arms or hold the arms static. And we compared the effect of these activities on the amplitude of the H reflex. Now, what you see over here is the H reflex when the arms were held static in a neurologically intact participant. Okay, here you see the M wave and you see the H reflex. Now, when the arms were cycling in the same participant, you see the overlaid trace here of the H reflex in red, and you can see that there is a substantial suppression of the amplitude of the H reflex while the arms were cycling. Now, what you see here are the changes in the amplitude of the soleus H reflex across all neurologically intact study participants that we had. And regardless of what the legend on the right here shows, which is really, it tells you that we had many experimental conditions, the consistent message is that arm cycling significantly suppresses the amplitude of the H reflex, showing a direct modulation of the lumbar cord by the activity at the cervical level of the spinal cord. Now, the question becomes, what happens after spinal cord injury? Well, we found out that after spinal cord injury, the cervical lumbar modulation is dysregulated. And oftentimes, we saw an increase in the soleus reflex amplitude during arm cycling, instead of the suppression that we saw in neurologically intact individuals. The very interesting thing is that after cycling training, the cervical lumbar modulation is restored. And this partly contributes to the improvements in walking and spasticity that we saw. So you can see that to address our third question, we can say that cycling training restores the cervical lumbar modulation in the spinal cord. So to conclude the talk, I hope that I convinced you that cycling translates to improvements in walking. And the arms play an important role in improving walking, specifically engaging the arms simultaneously with the legs in a coordinated rhythmic activity-based therapy produces larger improvements in walking ability than focusing on the legs only. The underlying mechanisms include improvements in corticospinal drive and cervical lumbar modulation. And what's very important is that the study participants were highly receptive of the intervention and they wanted to continue. So important take-home messages is that arm and leg cycling training can be readily translated to the clinic. It can be utilized to improve the walking capacity of persons with various neurological conditions, including multiple sclerosis, stroke, and Parkinson's disease. It restores, it reduces the physical work that physiotherapists have to apply during walking training, and it allows for effective delivery of therapy to a larger number of clients than currently possible with the existing staff. So I'd like to end the talk by thanking the outstanding team of trainees and support staff I have in the lab. This particular work was particularly led by Ray Joe, a previous graduate student in the lab, and by Trevor Bars, a current postdoctoral fellow in the lab, and by Behdad Parhizi, a PhD candidate in the lab. I'd also like to thank the funding agencies that have generously supported this work. Thank you.
Yes, any questions? Any questions to Dr. Vivian Mushawar? Just if you have any questions, you can text in chat box. We'll be asking behalf of you. Even after the event, just you can mail us. We'll be sending all the queries to concerned speaker. No questions, madam.
No problem. Thank you very much.
Yes. Thank you very much, madam, for participating in this event. On behalf of organizing committee members of Physiotherapy Congress 2021, we want to thank you for instant presentation. Looking forward to meet again next time. Yes. Yes. Now we ask Dr. Fariba Gadri from Faculty of Rehabilitation Sciences from Tabriz University of Medical Sciences from Iran to start the presentation.
Hi everyone, do you hear me?
Yes, madam.
Would you please share my screen?
Yes, I'm going to share.
Hi everyone, a special thanks to organizer, and it's an honor to be here with you today. Thank you for joining us in this session. I'm Dr. Fariba Qaderi from Tabriz University of Medical Science, and today I'm going to present our newest randomized clinical trial on the effects of interferential electrical stimulation current on labor pain and duration of active phase of labor in premaparous women. As you know, natural childbirth is the method of choice for delivery. However, labor pain is one of the most severe pains a woman experiences during her lifetime. Feeling labor pain is a subjective matter that depends on several psychological factors, cultural factors, and the number and severity of uterine contraction and the rate of cervical dilation. In recent years, several pain management techniques have been proposed to control labor pain, including drugs, complementary therapies, physiotherapy techniques, the use of herbal medicine, homeopathy, aromatherapy, hypnosis, and music therapy. Transcutaneous electrical nerve stimulation is one of the most common modalities which has been used in labor since 1970s. Many studies have shown its effectiveness and harmlessness. TENS is a low-frequency modality.
Hello, doctor. Excuse me, doctor. Hello? Just we are sharing behalf of you. Just you can play from our side. Yeah. Did you find your top on the screen?
I did it.
Yes. Just I'll be playing. Just you can read. Just you can explain.
Do you see my PowerPoint?
No. Just we are sharing from our side.
Share it, please. You have my slides. Share it, please. Thank you.
Yes. Yes. Do you find your PPT on the screen?
Please, number 4. Yes. Number 4, please.
Yes. Just you can start your presentation. Just after the presentation. Yes, you can start. As soon as you can mention the word slide change, I'll be changing from our side.
Slide
Yes, you
number
can start
4,
with your
please.
presentation.
Yeah. From the title, do you hear me? Excuse me, I don't hear you.
Hello, madam, start the presentation.
Just we'll be sharing from our side. You can start presentation. Hello, do you hear me, Dr. Fariba?
Yes, I hear you, but I hear you interrupted. Slide 4, please. Slide 4, please. Can you share it?
Is it fine?
Yes.
Yes, you can go on.
Please change the slide numbers if I want you to change them. Okay.
Okay.
Okay. Transcutaneous electrical nerve stimulation is one of the most common modalities which has been used in labor since 1970s. TENS is a low-frequency modality and have a limited penetration compared with medium and high frequencies. Several theories shows that medium-frequency currents reduce skin impedance and may ease penetration into tissues by currents with a frequency more than 1 kHz. Interferential current is a type of medium-frequency electrical stimulation and is effective in reducing pain, especially deep pain. Slide 5, please. What is the advantage of interferential current? This current arises from the interference of two asynchronous alternating currents with an average frequency in the range of 1,000 to 10,000 Hz. It seems that this type of electrical stimulation is easier to tolerate and more pleasant than other currents. The most important advantage of interference currents is the stimulation of a wider area of the body than the other electrical stimulation modalities. But the number of studies is limited regarding the use of interferential current to reduce labor pain. Given the advantage of medium-frequency electrical stimulation, including interferential currents for pain relief, and the inadequacy of studies on the effect of these currents on labor pain and the duration of the active labor phase, this randomized controlled clinical trial aimed to evaluate the effects of interferential current on labor pain and duration of the active phase of labor. In this study, other variables affecting the progression of labor and maternal and neonatal health were also studied. Number 6, please. Do you hear me? Methods. This double-blind randomized control clinical trial was performed on 60 premaparous pregnant women at the beginning of active phase of labor. These participants were randomly divided into two groups, interferential current and placebo, consists of sham interferential current using a random blacking method. Number 7, please. As you see in this figure, you see study flow chart. We assess 283 and we randomized them into 2 groups and we followed them and we did intention to treat analysis for both groups. Number 8. In all participants before the intervention and the initiation of active phase, 8 adhesive electrodes were attached and fixed 5 centimeters apart from the spine midline at T10 to L1 and S2 to S4 levels. Do you hear me? My connection is poor, unfortunately. Do you hear me? Do you hear me?
Fine, madam. Proceed.
What?
Yeah, fine, madam. You can continue the talk.
Please.
Hello. It's fine.
You can proceed with your talk.
Hello, madam. Start the presentation. Please proceed the presentation. Hello. Hello, Dr. Fariba.
Hello. Yes. Now, meanwhile, we go with other speaker. That will be Dr. So, just meanwhile, we'll go with 5 minutes break and we'll rejoin the webinar again. As 2 to 3 speakers are waiting, just within 10 minutes we join. Just we'll take a 10 minutes break and we'll rejoin again the event. Hope you understand. Hello.
Hi everyone.
Hello everyone, am I audible?
Yes, madam. Just you can start your PowerPoint uploading. Within two minutes, we'll be joining the present. We'll be starting the.
Okay. First of all, I am sharing my screen.
Actually, there was a network problem from the participants as they are staying from different parts of the world.
Okay, no problem. Can you see my PPT presentations?
Yes. Let me introduce, madam. Just let me introduce.
Okay.
Yes. Just. Next, we invite Dr. Heta Doshi from Neotech Institute of Physiotherapy from Vadodara, from Gujarat, from India, to start the presentation. And the topic of the title will be that the study, the efficiency of medical ball training versus kira ball training to improve the upper body strength as well as throwing accuracy among shot put players, like comparative study, a comparative study.
Yeah.
Yes.
Thank you so much, all the team members of the Inovine committee, and thank you so much for providing me these types of study on your platform. Now let's start. As you all know, my study title, that is, it is a comparative study between the medicine ball training and kettlebell training among shot put players on the for the two things, that is upper body strength and throwing accuracy. Now, for this today's this session, we have all seen, that is, these types of content, that is the introductions made of the study, aims and objectives, hypothesis, methodologies, statistical analysis, result, discussion, conclusion, summary, limitations, and further recommendations, and the last is references. Now, shall we begin the session on this title, that is the introductions. Shot put is a track and field event where the shot putter throw in a pushing motion, a heavy shot that can be thrown as far as possible. Shot put is a dynamic event that demanding high power production, and its performance in this event is mostly determined by the release of velocity of the shot, as everybody knows. For the shot putter, there are most commonly two techniques are used. The first technique is the glide technique, and the second technique is the rotational technique. Both techniques differ from the initial state, but the delivery phase are similar in both the techniques. Okay, now in shot putter, there are the initial drive from the legs, which has generated a lots of energy, and that can be transmitted from lower limb to upper limb with the midsection, that is the abdominal section. In the abdominal sections, there are so many muscles are there. The most common muscles are widely needed, strongest, that is the oblique muscles, rectus abdominis, and the transverse muscle. It must be strong and rigid for the support and effort of the thrower's arm, the leg, while securing the no energy is lost. For the delivery of the shot putter rotate their upper body by using oblique muscles, right, as a shot putter technique. But for the throwing of the shot, it is also needed some energy from the upper limb, and the muscles are pectoralis major muscles of the chest and the anterior fiber of deltoid, front shoulder muscles, tricep brachii, or the rear of the upper arm, which demand the technique along with the strength, alterations in throwing style, which earn the power of thrower and the distance achieved. Okay. Almost 75% of the throwers present with one or more injury of the throwing arm during their career. And among this 75% of the throwing injury, there are 70% are injury most commonly seen in the shot put, that is on the shoulders. The strength training and the throwing are single biggest factor in the training, because throwing require a great deal too for the strength and the power. There are so many techniques for the shot putter, but there are so many less study on the shot putters. We have doing this study for doing only two types of training in the two different groups, but the medicine ball training, which are closely mimic to the sport specific action, it is shows the positive transfer effect on the muscle strength and the power that periodized medicine ball training, which can significantly improve functional performance, throwing velocity, and the strength of upper extremity. Because of the medicine ball training, it it most commonly permit as a sport specific, and it is a complex movement which transfers intensively and greater resistance than during regular sports competition in a specific manner. But as a kettlebell training, which increase the demand for the dynamic joint stabilization, which decrease the chance of injury and allow more efficient force production, which also used in the rehabilitation setting to develop mobility and stability, which can be used in a conditioning of endurance athletes, and they can be used to improve explosiveness in the power athlete. For this study, there are so many studies showing the effect of medicine ball training and the kettlebell training alone on the throwing performance and upper body strength. But no one can study for the comparison which training is best for the shot putter. So my main purpose is for the current study that to evaluate the effect of medicine ball training and the kettlebell training in improving upper body strength and throwing accuracy amid shot putters. And the result of the study may be helpful for the shot put player to know that throwing accuracy, upper body strength, and improve the skill performance. My main aim is to compare the efficacy of medicine ball training and kettlebell training to improve upper body strength and throwing accuracy among shot putter players. But other some objectives for this study as to determine the effect of medicine ball training on upper body strength, to determine medicine ball training on throwing accuracy, and to determine kettlebell training on upper body strength and kettlebell training and throwing accuracy. And also I have compared for in this study that is which training is best for the shot put player within a 6 week of interventions. Okay, now let's see the hypothesis, that is there is null hypothesis is no significant difference between these two training for within a 6 weeks of intervention. But alternative hypothesis, that is significant difference in comparison of effectiveness of medicine ball training and kettlebell training within a 6 weeks of intervention on upper body strength and throwing accuracy in shot put player. Now for this study, the methodology, that is source of the data, I have taken shot put players from the Parole University campus and the sports complex. The sample size is total number of population I have including in this study, that is 30 samples. And for the both the group, I have including 15 athletes, that is the shot put players in two groups. Selection of the sample, selective sampling who fits in the inclusion criteria, that is by using computerized generated software for random sampling. Study design is a comparative study. Treatment duration about most commonly 15 minutes and 3 sessions per week. But my study duration is 6 months and intervention duration till 6 weeks. Ethical clearance for this study also taken from the Parole University Institutional Ethical Committee for the Human Research. Also a written consent was taken from each subject who have participated in this study, and that is also saved with me. Criteria for this study, that is I have including in this study the shot put player age is 19 to 25 years and participant will be given written consent. Player has been playing a shot put from last 3 years or participant have experience of 2 competitive events of the shot put. Each participant, male or female, that I have not a specified gender. Exclusion criteria, that is I have excluding in this study, that is if any history of any participant pain over a shoulder joint with past 2 months, cervical spinal pathology, spine deformity, any glenohumeral subluxation dislocation within a 6 months, subject is unable to give return consent. If participant have any surgical history, any injury, any pathology, I have excluded that. If person having taken any corticosteroid injection in a shoulder within the last 3 months. Okay, now for the procedure for this study, that is I have assessed that 42 shot put players, but for as per inclusion exclusion criteria, I have only including 30 participants. 12 participants are excluded because they did not match inclusion criteria, and there is 30 participants who have selected, that is computer by the using of computerized generated software. They are divided into 2 groups. Group A received medicine ball training and group B received kettlebell training. Okay, now exercise protocol. Selected player, that is 30 players are selected, were divided into two groups by using computerized generated method for randomization by using research randomized software. After all inclusive criteria added, each subjects and therapists both are blinded for the grouping before starting the exercise. Introductions of all the exercise already given to the each participant. Group A that received medicine ball training and Group B kettlebell training. Both group had a mandatory for 15 to 18 treatment session within a 6 week when they have starting their training. There was 40 to 45 to 50 minutes of exercise protocol which had a three phase. First is a warm-up phase, second is exercise phase, and third is a cool down phase. Warm-up phase most commonly 5 to 10 minutes approximately we have given. That is, in the warm-up we have including jogging 800 meters, rotational exercise of neck, arm, trunk, leg, swinging exercise of arm across the body, leg in the beginning swinging across the body towards the front and back. We have already taken for some precautions for all the players, that is all players have to while hydrated. Exercise should not be done immediately after the meal. There should be an hour gap before and after the exercise for a meal. If any kind of exercise causes hurt to the patient, immediately stop that exercise and inform the instructor. Okay, then this is the protocol for particular shot put players for giving a medicine with the help of medicine ball training. Medicine ball training we have taken for the first week, second week, third week, fourth week, fifth week, and sixth week. Each week we are given different types of protocol, that is standing each and every functional training, that is standing shot put throw, sitting shot put throw, single-handed shot put throw, single-handed, that is the right and the left side hand shot put throw, jumping shot put throw. Each and every week there is a different beat of medicine ball training, different time for training, different repetitions of training we have including in this protocol. These are some pictures during we have taken during the training. For second, that is a kettlebell training. For the kettlebell training, we have given kettlebell training with the different types of kettlebell weight. And first, second, and third day in each week, we have different types of protocol. We have already followed that. Then this is also a pictures we are taken during the training. Then this is a cool down program that is slow jogging 400 meter, static stretching, flexibility of upper body, lower body, and the abdominal muscles. And warm up and cool down period both are same in two groups. Predictor outcome for training, we have taken this predictor outcome before starting the intervention, and after the 6 weeks of training we have taken this protocol. During this we have also taken this outcome measures after the completion of third week. The three predictor outcome we have measured, that is 1 RM bench press for the strength of upper body, medicine ball throw test, that is with the help of single arm seated shot put test for the throwing accuracy, and functional throwing performance index for functional performance level among the all shot putter. The statistical analysis, all data passed with the normality test with p-value that is more than 0.05 and follow Gaussian distribution. All the statistical analysis were calculated using alpha level of 0.05. Normality of the data was checked by Sapir-Whorf test. Descriptive statistic was used to analyze baseline data for the demographic data, and baseline data are all similar for prevention of the biasness. Pair t-test was used to find the significance of parameter pre and post value for within a group, and independent t-test for comparison of both the group for all the parameters. These are the summarized which tests we are using for each and every comparisons within a group. We have taken pair t-test for all the outcome measure, and unpaired t-test we have taken for comparison of mean between a group. This is some baseline data for the age, height, and weight. This is the age distribution, that is 23 to 25 years of the age. There are the three populations, 21 to 22 years, that is the 53% populations, and 90 to 20 years of the age, that is the 44% of the population. Then this is the distribution, that is among this study we have already including 30 participants, but out of 30 there are 23 male participants and 7 are female participants. Hand dominancy, there are 80% are right-handers, but 20% are the left-handers. Among these, all the baseline data we have checked the normality. Then comparison of pre-post value in functional throwing performance index for group A and group B. When we compare group A and group B, there are the mean value already shows pre-value, that is a functional throwing performance is 58.29 in medicine ball training pre, but 82.84, that is a post. That shows a significantly improved, that is highly significant result. Same in group B, also the highly significant difference. Then pre-post value for in medicine ball throw test, that is also there is a highly significant difference between in within a group pre-value and post value. When we compare, there is a highly improved and highly significant. Then also one RM bench test for group A and group B within a group comparison, there is also sees that we have says that pre-mean value and the post-mean value, there is a highly significant result. And same for the group B, that is kettlebell training, is also shows that there is a highly significant difference. But when we compare between group for functional throwing performance index, there is a mean value for the medicine ball training 24.54%, but in group B there is also 23.82%. There is a 1% of the difference, but that shows that there is no significant difference between group. That means if pre-post comparison within a group, we say that this training is improved. But when we compare which training is improved, this shows that there is both are similarly improved. 1% is not a major that, right? So this is not a significant result. As for the medicine ball throw test, there is also sees that 6.93 in medicine ball throw test, and in group B medicine ball throw test, that is a kettlebell training, that is 6.53. That is also shows that not significantly result. After that, the 1 RM bench test is also says that this result is not significant. Now, the summarize of this all the results, this result shows that group A and group B are having significant improvement when compared pre-post data. There is no significant difference between group A, that is a medicine ball training, and group B, that is a kettlebell training. In short training of group A and group B, both are better and more powerful. Individuals who participate in this training program, including medicine ball training and kettlebell training for 6 weeks, the outcome functional training performance index, all the outcome measures show significantly improve. The discussion, that is both medicine ball training and kettlebell training increase upper body strength and throwing accuracy by producing more powerful contraction. But when the results are compared, statistically it is similar, but clinically there are significantly improved. Similarly, medicine ball throw test, that is a functional training, and it shows that functional training also improve the performance-based training, and it is a movement-specific adaptation for increased amount of specific angular velocity. But for as a kettlebell training, there is also shows as a stimulate the joint specific receptors, and it is also prevent the joint injury. It is also mobility and stability exercise. So the kettlebell training is also improved. Now the conclusion of the study is it supports null hypothesis that shows that there is no significant difference between a group. Individuals who participate whether in medicine ball training or kettlebell training, both training shows improvement in functional performance, upper body strength, and throwing accuracy. Both groups experienced a statistically and clinically important improvement in upper body strength, throwing accuracy after the training. But it should be noted that group A and group B show similar significant improve after the 6 weeks of training. For the limitations of this study, that is, this study was done in a small area, so we have not taken further follow-up after the 6 week. Result are generalized. It is not a specific in terms of gender. Throwing velocity angular of the throw was not measured because of lack of technology. We could not check in which phase of throwing motion the chance of mechanism of injury are more prone due to lack of technology. In short, the study considered that least number of participants makes it difficult to detect small possible difference between a group. Study did not focus on the trunk and lower limb muscle strength. Further recommendation for this study, that is, we should be taken large sample size. The duration of the study should be elongated for the better effect in both the group. We have done this study to determine the clinical applications of this exercise regime for different age group and different sports. Owing of the growing popularity, the youth strength and the conditioning program, additional long-term trial should be undertaken to see the neuromuscular mechanism. It should be there may be possible the neuromuscular mechanism are more effectively in children and adolescents. Similarly, this study may be taken to physical education, teacher and coach to improve the other skill. Further study should be done to compare the different training to improve skillful performance in a sports. These are some references. Thank you so much.
Yes. Any questions? Any questions to Dr. Ita Doshi? Just if you have any questions, you can text in chat box. We'll be asking behalf of you. Even after the completing of the conference, we'll be sharing their questions to all the participants. Any questions? Thank you. Thank you very much, madam, for participating in this event.
Thank you so much.
Yes, on behalf of Organizing Committee member of Physiotherapy Congress 2021, we want to thank you for your presence. Looking forward to you meet again next time in the physically when everything goes well. Yes. Now, next we invite Dr. Zoltan Alfoldi from Faculty of Health Sciences from University of X from Hungary to start the presentation.
I hope my presentation is ready.
Yes,
Everybody?
Yes, it's fine, sir.
Okay, thank you very much. So good afternoon, everybody. Anthropometric and physiologic characteristics of elite male, female, junior rowers. So about the introduction, rowing is a competitive sport where both males and females of all ages compete. Rowing can involve a single individual or a crew of people consisting of 2 to 8 members, of which are known as oarsmen. Across various countries, rowing is widely known, allowing it to become an Olympic sport where two separate disciplines of rowing are used, sweep rowing and sculling. In sweep rowing, the oarsman will handle one oar, whereas in sculling they will use two oars. Regardless of the discipline, the objective of rowing is to move a boat across a body of water for 2,000 meters, which lasts approximately 6 to 8 minutes. The movement of an oarsman consists of the large movement of the legs followed by a more significant movement of the trunk and the minor contribution of the arms. During a race, the use of both the anaerobic and aerobic energy pathway is expected, approximately 30% and 70% respectively. Along with the physical demands of rowing, environmental condition will influence the outcome of a race. For studies examining physiological parameters of rowing, these environmental factors can affect the validity of the studies. Over the years, the use of rowing ergometer has become the most widely used method to help combat this problem. A rowing ergometer is used indoors, allowing for a controlled environment with the intentions of mimicking the same movement one would use during water rowing. The aerobic power during a rowing ergometer can be measured in a similar way as a researcher would examine metabolism during cycling. Higher capacity of VO2 max results in faster rowing times as to the body using oxygen more efficiently. Cosgrove et al., Yoshiga and Higuchi, and Raswell et al. Indicated VO2 max as one of the best predictors in rowing performance when evaluating male rowers. Other variables influencing rowing performance include the anthropometrics of lean body mass, height, and long limbs. When examining female rowers, Battista et al. Found the vertical jump and year of experience before colleague were the most significant indicator between novices and varsity athletes, supported by Hung et al. And Ingham et al. The winning time and the world record holder for women's rowing, in fact, 16 slower than the men's record. Research determined the outcome to be due to women having a smaller body frame and lower lean body mass. The large body frame indicated a longer stroke length, which result in a larger amount of ground covered. A higher lean body mass indicated an individual having more muscle than fat. And the sport of rowing requires almost all muscles of the body to be used. Methods and procedures. 15 rowers, 6 males and 9 females who participated in the Hungarian National Rowing Championship 2020 conducted a 2-kilometer rowing performance test on rowing ergometer in the Human Performance Laboratory in Győr, Hungary. The males were ages 15 to 16 years with an average 6 years of training. The females were aged 15 to 18 years with 3 years of training. All subjects were highly ranked in the Hungarian Rowing National with top finished at the national rowing competitors. The 2000-meter rowing times from the Hungarian Junior Rowing Championship were reported. Each subject was measured for stature and body mass with the stadiometer to the nearest 0.9 centimeter and calibrated scale to the nearest 0.1 kilogram. From the measures, body mass index and body surface area were calculated. In addition, sitting height, arm span, limb length using standard anthropometric procedures were taken by the same technician and reported in centimeters. The body composition was measured using an in-body 720 bioelectrical impedance analyzer to obtain percentage fat and lean. The Athletic Club of Győr allowed the research team to access data and information consistent was provided. The study was conducted ethically according to Declaration of Helsinki, and it was approved by the Bioethics Committee at the University of Pécs. Each subject was asked to perform a count movement jump from force plate PGS 4P60S to determine maximal force and the rate of displacement. From these measures, jump height and peak power was determined. Using the body mass of the subject, the relative peak power was calculated. Each subject was asked to perform a 2000-meter rowing task as fast as possible. All rowing in the lab were performed using a rowing ergometer. From the average power was determined and time to complete 2000 meters. During the test, a measure of oxygen consumption and carbon dioxide production were taken using indicated calorimetry Jaeger Wintux CPX. And in addition, heart rate was monitored using polar heart rate monitoring age 7 with Bluetooth smart technology. Peak heart rate, VO2, and VCO2 were recorded. From these measures, oxygen pulse was calculated. The statistical analysis, all data from each subject were organized by sex and entered into SPSS-X version 25 spreadsheet. Descriptive analyses were used to report mean and standard deviation of all variables. The relationship between laboratory performance and field roving performance were tested using a person correlational analysis, since field performances were potentially affected by temperature, water condition, and race strategy. The laboratory roving performance time was used as the outcome, which other variables were entered in a stepwise regression analysis to identify predictors of the outcome. About the results, the mean anthropometric measures and body composition for all study participants and separated by sex are reported in Table 1, while jump variables are reported Table 2. The Table 1 mean anthropometric measures and body composition. Body mass 68.8, stature 176.6, BMI 22.1, BSA 1.7, fat percentage 19.5, lean percentage 37.3, sitting height 93.3, arm span 179.3, and limb length 102.3. The table 2 mean of counter movement jump variables. The peak performance 1569.9. The rate of displacement 2.5. Relative power 47.9. The time to complete the 2000 meters on water was on average 444.4 seconds, while the time to complete the 2000 meters on the roving ergometer was 453.3 seconds. The relationship between these two performance times were strong based upon a person correlation coefficient. Figure 1 illustrated this relationship for the group, including the trend line and line of identify. The physiological variables measured during the roving ergometer test are reported in Table 3. Time to compete 453.3. Average power 250. Average cadence 49. Peak heart rate 180.8. Peak VO2 3768.3. Peak VCO2 4301.8. Oxygen pulse 19.8. The percentage lean tissue, arm span, fat percentage, sitting height, peak VO2, and peak force while jumping were chosen for regression analysis to the strength of their relationship with 2000 meter roving performance. The stepwise regression indicated that peak VO2 and lean percentage were identified as significant predictors of the time to complete 2000 meter roving distance according for 89 of the shared variants. Peak VO2 was identified as significant predictor of time to complete the 2000 meter roving distance according for 83% of the shared variants. The linear regression equation are the time to complete 2000 meter rowing equal to 670.87, and all other variables entered into the stepwise regression were excluded. As average power directly influences the rowing performance, this variable was excluded from this analysis so as to identify other factors. About the discussions, this descriptive study of junior rowers identified the importance of aerobic power as a predictor of rowing performance. Since the mean power was highly related with the time to compete, the rowing distance factors that reflect power might also be evaluated to confirm these findings. The average cadence for each subject was not related to average power and therefore not considered a factor. The ability to generate force in the legs has been suggested as a factor for rowing, although the relationship between these variables was only moderately related. The upper body size of the individual seems to play a role in rowing performance, as evident by strong inverse relationship between performance time and sitting height and arm span. However, since these variables were not selected in the regression equations, do not as strong as the metabolic and body composition measures. If these laboratory measures were not available, then these measures could explain some of the variance in rowing performance. In this study sample, the limb length did not relate to performance time, however. The findings of this study support the idea that an elite rower should possess a high rate of oxygen consumption. If profiling an elite junior rower using the relative rate of oxygen consumption to the body mass might be considered more appropriate. For this group, the relative rate for the entire group averaged 54.1 milliliter per kilogram per minutes, with the male rowers averaging 61.2 milliliter per kilogram per minutes, and for females 50 milliliter kilogram per minutes. These measures as peak values over to 6 to 9 minute period of rowing reflected a high contribution of aerobic metabolism. The corresponding heart rate responses indicate a near maximal exertion during this bout of exercise. These findings are similar to others in that a higher VO2 max was predictive of rowing performance. Further studies are needed to identify the race performance on water, and the impact cadence in a group crew requires a level of power of force in rowing to contribute to propelling in the boat toward the finish line. Also, if lean body mass, particularly skeletal muscle, is predictive of rowing performance, what are the forces from the lower and upper body dynamic muscular contraction which generate an effect stroke within the cadence of the crew? This study not evaluate the anaerobic power nor body strength of these rowers. ACCHA reports the for colleague age rowers and anaerobic power evaluated using a modified Wingate test, along with strength measures, explain the majority of the variance in 2000 meter rowing ergometer performances. As these variables are expected to improve in adolescents based upon maturation, more studies are needed to recognize the role of maturation in junior rowers. In conclusion, this study results identify the role of aerobic power on rowing performance. In addition, the percentage of lean body mass offers an additional contribution to explaining the rowing performance in this age group. Why rowing performances might be explained by these measured variables, more study into the movement mechanics and force application along with the impact of strength and anaerobic energy in maturing adolescent rowers are needed. Thank you for everything, and thank you introducing Mr. Kevin.
Any questions? Any questions to Dr. Zoltan Alfoldi?
Okay, thank you very much. Say hello.
I think no questions, sir. Yes, thank you very much, sir, for participating in this event. On behalf of
Hello,
committee member.
Yes, can I ask Mr. Zoltan a question?
Yes, definitely, sir. Just you can go on.
Okay, it's out of the topic. My name is Dibal Salim, and I'm graduate from Semmelweis University. I wanna say Kosunam, Nagyon Kosunam, Nagyon Kosunam szépen.
Thank you. You can speak Hungarian. Yes, very well, very well. Köszönöm szépen. Köszönöm szépen.
Yes. Any questions further?
No further question from my side.
Thank you very much, sir. It was nice talking to you. Thank you. Thanks for sharing your tips with us. Yes, looking forward to meet again next time.
Okay, thank you very much.
Yes, yes. Next, we welcome Dr. Deep Naif from Al Salim from King Abdulaziz Medical City from National Guard Health Affairs from Saudi Arabia to start presentation. It is a just you can upload your presentation, sir. We would like to inform that Dr. Deep is the yes, you can continue your talk, sir.
Okay. Good day. My name is Deepak Salim. I'm introducing you a case study regarding early physiotherapy interventions for severe traumatic brain injury, communicate with the stroke on the right side weakness. Okay, so we can start. First of all, traumatic brain injury, it's causing by falls 47%, stuck by agonist 15%, and 8% unknown cause. And also, my case was around, about a traffic accident, actually, which is recover after a severe traumatic brain injury that involve a prolonged immobility and result in decreased balance, strengthening, and endurance, and so increasing the risk of secondary complications such as wounds, contracture, respiratory illness. The purpose of this case report, it was described the sudden progress from acute courses toward the subacute and chronic phase of rehabilitation of a patient with severe TBI, followed by subsequent stroke for the right side weakness. That's my case, and emphasize the role of physical therapy in preparing the patient for the next level of care. This is a 16-year-old male in 10th August 2019 post-motor vehicle crash after front-seated and ejected from the car, admitted at local hospital, where poor acute management, no physiotherapy was addressed to the patient, and a severe traumatic brain injury was presented and diagnosed. And a couple, like 1 week later, he transferred to Advanced Hospital, where he had a prolonged hospitalization complicated by ventilator associated with pneumonia and respiratory failure, and physiotherapy was there from day one. In this case report, early functional mobility training was proposed based on well-documented evidence to an aid and validity in improvement patient outcome. Physical therapists who are specialists in critical care unit and ICU work to progress the quality of life and physical function, peripheral and respiratory muscle strengthening, escalating to ventilator-free days. and reducing the hospital and ICU stays as per the evidence-based review of acute brain injury project. There is a project is running around the medical cities called the acute brain injury project, where PT coming in the first day referred to PT, and we started our intervention with the patient. This is a level 2 evidence to assist that early rehabilitation is coming together with better outcome, such as length of stay and shortcomes, better functional dependency measure, VIM scores, and tremendous cognitive level of discharge at discharge, and greater likelihood of discharge to home as well. So the case to analyze it, was like very complicated. It started with TBI. There was like a wrong interventions come to the patient medically, and anticoagulation was administered in the wrong way, and it's complicated with the patient coming with us with a wide spread of outcome measure and related to the VIM scale generated, and a easy to use and readily available tool for clinician and audit a patient functional status. It relies on the reliable measurement of determination of the level assistant property and mobility task. And so, yeah, so we analyzed the case by started a quick assessment on him, beginning on the ICU. I was there, myself, and the patient was in total flaccid stage for the right side. And we placed the MRC scale for the non-affected side and measured scale as it's showing for the affected side to see if there is any sign of spasticity could come in, or any hypertone could come in from the patient. Then patient goes from ICUs in a couple of weeks to the ward, to the floor, to acute setting. In acute setting, patient was not able to give any express due to the expressive aphasia that patient developed from this accident. He developed like expressive aphasia. He developed, patient was not able to give a feedback in communication. Then he was very young, he's 16 years old, and we want to get him back to school if possible. So 2 to 3 weeks later, patient developed like psychological effect post-accident, and he asked to be discharged. Then, as per policy, patient is allowed to go to be discharged and went home, then follow with the PT as an outpatient. When you follow with the PT as an outpatient, PT show that the patient can have better outcome if he transferred to intensive rehab unit, where I'm working in the National Guard. Patient then came to us, and we addressed a full assessment for admission under rehabilitation, intensive rehabilitation, physiatry team, nurses, rehabilitation nurses that they are having experience in the rehabilitation and rehabilitation programs, and physiatry lead by our consultants. And there is like OTs in the side, there is speech therapist also in the side, and physio, our team in the side as well. We all one team for this patient. We stood up for our functional ability and mobility for the patient. We made these kind of interventions from first week to from first week to 3 weeks. Patient was in the acute setting. He came to me from 4 weeks to the 15 weeks. In the 4th week, patient already was able to do sitting balance, but in dynamically he wasn't. He was fair, maybe closely to bull. But then we developed from 4 weeks to 12 weeks with standing exercise and weight shifting exercise, balance exercise as well. We develop a standing, reach like fair and dynamic standing balance. in the 13 to 15 to the 15 weeks, spasticity was so strong, then we asked the team to administrate anti-spastic drugs, included Botox injection for the gastrocnemics and solos as well. And we ask also for the upper limb, except for the hamstring, because we needed for the patient to help him in standing. Dynamic AFO was administered to the patient, and Hemi Walker was also given to the patient. Patient was able to develop a quick improvement from sitting to standing to ambulation few steps. Then with the dynamic AFO, which can be shown here, it's in this shape. It's not like the regular white one, if you're familiar with it. It's like in this shape, dynamic one, and it's help patient to ambulate even farther distance using AFO and Hemi Walker. The result you can see here, we have reached to the point that patient was able not only to use the Hemi Walker, also to use the quad cane, and that's really impressive, really impressive. And the result research on multidisciplinary team and goal-orientated was highly needed. A clinician should manage the treatment by the functional goal of neurological rehabilitation. And conclusion and suggestion is more research is highly needed to expose to the effectiveness of specific physical therapy intervention to facilitate motor recovery and ultimately functional recovery in the traumatic brain injury community. And that's it. That's it. Is the reference. So any further question?
Yes, any questions
about the case?
Yes, any questions? Any questions to Dr. Deep Salim? Just if you have any questions, you can text in chat box. We'll be playing behalf of you.
Okay. That's it. So no question.
Yes,
I want to thank you so much for having me again, and I'm willing to have. I'm willing to participate also in the next time as well. Thank you so much.
Yes. Thank you so much, sir, for participating in this event. On behalf of organizing committee member of Physiotherapy Congress 2021B1, thank you for presentation. This was your second conference that you are joining in this event, sir. Thank you very much. Yeah.
You're welcome.
Yes. Next, we welcome Dr. Mariam Sadut from University of Medical Sciences from Iran to join the event. Yes, Dr. Mariam Sadat, just you can start your presentation by uploading your PPT. Hello. 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 Yes, there was a error from your side, madam, regarding your video presentation. We are unable to play your presentation. We asked Dr. Sahid Vahid from Sports Medicine of Center from Astan Qudus, Razvin Institute of Physical Education from Iran to start the presentation. Yes, sir. Dr. Syed, you can start your presentation. Hello. Yes, sir. Dr. Syed, you can start your presentation. We asked Dr. Syed Wahid from Sports Medicine of Center from Razavi Institute of Physical Education to start the presentation. As was actually there was an error in network from Dr. Mariam Saad. The video presentation that she showed is not presenting. Sound was better. Presentation.
Hello.
Yes, doctor.
Hey, how are you?
Yes, you can start your presentation.
Okay. Right now?
Yes. You can take your own time.
Okay. Can you see my presentation now?
Just you can start your presentation by uploading your PPT. No, we cannot see your PowerPoint.
Okay. Stop recording reactions.
We have a lot of time, sir. You can take your own time.
Okay. So how am I going to open my presentation you to see?
Yes.
What should I do? I'm just opening the presentation, but you don't see, right?
Just you can in bottom of the screen you can find with the share screen. Bottom of.
Okay.
With the green color you can find with the
Okay.
share
Share
screen.
screen, desktop weapon, desktop one, share, open system preferences. Okay. Is it working now?
No, no, sir.
Okay. I'm saying.
Yes, it's going to start.
Okay. It says open system preferences. I changed it from the open preferences, but I don't know if it's not working. Can you see now?
No, sir.
Okay. It says you have to close Zoom and come back again. Should I try it?
Yes, you can try it.
Okay, let's try.
Yeah, yeah. Hello. Just
hello. Yes.
You can open your PPT, sir. We don't find your PPT on the desktop. Just you can. Everything is fine.
Okay, but it's not. I can see you here, but
sir,
we don't use normally Zoom. We are
just
using
listen me, sir. Your screen is already sharing. Just open your PPT.
Okay.
Remaining windows, minimize the remaining windows.
Okay, so
it's working.
Yes,
Work.
yes, it's
you can
fine.
see now. You
Yes.
can see now.
Yes.
Perfect. Okay. Okay. So everything is fine now. I can start. Right?
Yes, you can start.
Okay. Hi, everybody. We are going to talk about resistance training in elderly. First, we have to understand what is aging. So then we can talk about the process and what's changing in the body and what we should do. Aging is the process of change in the organism, which over time decreases the probability of survival and reduces the physiological capacity for self-regulation, repair, and adaptation to environmental demands. This definition was done in 1988 by Scrooge and Biron, and we are facing with some facts about aging all over the world at the moment. According to WHO, between 2015 and 2050, the proportion of the world's population over 60 years old will nearly double from 12% to 22%. And number of people aged 60 years and older already outnumbered children younger than 5 years old. In 2050, 80% of older people will be living in low and middle income countries. And the pace of population aging is much faster than ever. So the population of the world is getting older and older every day, especially in the developing countries. As you see again in this graph, the elderly population, the population aged 60 years old or over is increasing all over the world, especially in the developing countries. All countries face major challenges to ensure that their health and social systems are ready to make the most of this demographic shift. When the population changes from younger to older, everything that we are going to face with is going to change in time. So that means we have to get prepared psychologically, physically, mentally, financially. The health system should accommodate this new situation as well, because it's going to be a big change in upcoming decades. So what are the physiological changes with aging? What we see, we're seeing decreased muscle mass, muscle strength, muscle power, muscle endurance, muscle contraction velocity, muscle mitochondrial function, muscle oxidative enzyme capacity, maximal and submaximal aerobic capacity, cardiac contractility, maximal heart rate, stroke volume and cardiac output, nerve conduction velocity, balance, proprioception, gait velocity, gait stability, insulin sensitivity, glucose tolerance, immune function, bone mass, bone strength and density, collagen cross-linkage, cartilage, and tissue elasticity. These are all decreasing with aging. So basically, what we need, what we like to have, everything we like to have and what we need are decreasing with aging. Some things are increasing, which are arterial stiffness, myocardial stiffness, systolic blood pressure, diastolic blood pressure, visceral fat mass, total body fat, intramuscular lipid accumulation is increasing. Again, basically, what we don't like to have are increasing. So it's a process of losing the good things and increasing the bad things in our physiology. And if you check this slide, that you're going to see many changes in almost all systems, and none of these changes in behalf of the wellness of the person. This is also a very important slide. It's from WHO. It was used in many places. You can see in many places the original and the modified ones. What we are seeing here is the change in muscle mass and strength with age. What we need to understand is we are seeing an increase during the early ages, and what we are doing here, if we increase the strength and muscle mass to a higher level, because there is a range of mass and strength in individuals, this is the range. So you can be either here or here, according to what did you do in these past years from the beginning to the end. So if you increase the peak muscle mass and strength over here, then when you come to a certain age, when you start to maintain or slowly lose the muscle mass and strength, you will start from a higher grade. But if you could come over here, you will already start here. And the most important one, probably, the maintaining the peak. So during the adult life, we need to maintain these muscle mass and strength as close as the peak values to here. So if we can do it, we will, when we go to a certain age, we're going to be here. But if we don't do it during the adulthood, then we are already here. And this is very close to disability threshold. And disability threshold also changes according from people to people. So what we are trying to do is to increase the muscle mass and strength in early life, in developmental ages, and then in adulthood to maintain it as high as possible. And then in the elderly, we try to minimizing the loss. So what we are trying to do is to make people follow the upper line, not the lower one. So when you come to the end of the age and end of the time, then you're going to be far from disability threshold. So you're not going to be disabled, you're going to be independent. So it's very important to understand this slide. It's very important slide. And when we compare the strength and muscle mass, this is also very interesting. We are seeing that the loss of muscle mass is much slower compared with the strength loss. So we are losing our strength much faster than we are losing our muscle mass. So it's not going parallel to each other. We are losing strength faster than we are losing muscle mass. These are the top 10 chronic conditions that we are facing with aging. I'm not going to talk about them because we have a very limited time, but just for you to see what we are, the hypertension is the most common one, and followed by high cholesterol and arthritis and going so. And then the terminology started to establish for aging and muscular side of aging, muscle physiological side of aging, and the term sarcopenia come to the table in time. In 1997, the terminology, it was defined, sarcopenia was defined as age-associated loss of muscle mass and function. And then 1 year later, in 1998, a muscle mass index was created, and it was told a muscle mass index less than 2 standard deviations below the mean of a young reference population. Again, in time, this definition continues to change, and European Working Group of Sarcopenia in old people defines sarcopenia as a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength. So muscle mass and strength are accepted as 2 parts of sarcopenia, and which diagnosis requires presence of low muscle mass plus either low muscle strength or low physical performance. So basically 3 different parameters was taken into consideration in this. First, muscle mass, then muscle strength, and physical performance. So these 3 were very important for the definition of sarcopenia. After 10 years, or almost 10 years after this, again, the European Working Group of Sarcopenia in older people defined sarcopenia as formally recognized as a muscle disease with an ICD-10-MC diagnosis code that can be used to bill for care in some countries. So it was accepted as a syndrome. So sarcopenia is the result of aging, but it's not a physiological follow-up of aging, it's a syndrome. And there are some other terms coming through, and when you see them, I'm just explaining these, not you to get confused, because you can see these terms as well. But the last definition of sarcopenia consists all of these terminology inside, because of the definition already shows functionality, strength, and muscle mass. But dynapenia is explained or defined as age-associated loss of muscle strength that is not caused by neurological or muscular diseases. So dynapenia is a situation, is not a syndrome. It's explaining the physiological changes in muscle strength, and it's not caused by neurological or muscular diseases. It's not a syndrome, it's not a disease, it's the age-associated loss of muscle strength. So don't get mixed the terminology with sarcopenia and dynapenia. It was explained by Clark and Manini in 2008. And then Morley et al. Add another term to this terminology as cratopenia to characterize the loss of force. And it explained dynapenia as loss of power. So they use different terminology for loss of force, loss of power, but the main difference is this is the normal follow of the aging, but sarcopenia is a syndrome. So what's happening with sarcopenia? What are the consequences of sarcopenia? The increased risk of falls and fractures, impaired ability to perform activities of daily living. It's associated with cardiac disease, respiratory disease, and cognitive impairment. If you remember the slide that I showed, the top 10 chronic problems, top 10 chronic okay, I think I lost the
Hey, my God.
sharing.
Yes, Dr. Syed has done.
Sorry?
It was a mistake from other speakers, sir. Just you can start again.
Okay, no problem. Can you see now?
No, sir.
Okay, I have to open sharing again.
Yes, yes.
Okay.
It was a mistake from other speaker.
It's okay. Can you see now?
Yes, sir.
Okay, thank you. Okay, so if you remember the slide that I already showed, that the top 10 chronic situations in the elderly, cardiac disease, respiratory disease, and cognitive impairments are over there, and sarcopenia is highly related with these conditions. And it leads to mobility disorders, lowered quality of life, loss of independence, or need for long-term care replacement, and at the end, death. It's very associated with death. Sarcopenia is very important. That's why sarcopenia is very important for elderly. And it's not just the health side of the situation, but also it creates financial problems like increased risk for hospitalization and increased cost of care during hospitalization, especially if you think that the elderly population is increasing in the lower and middle income countries, developing countries. So these costs are getting more and more important. Strength is, this is very important. Strength is associated with all-cause mortality in older population. So that means the stronger the elderly, the lower the risk. In all types, in cardiac reasons, cardiac mortality, respiratory mortality, and overall mortality, everything is decreasing with strength increasing. Sedentary people lose large amounts of muscle mass. These are the reality about aging, like in dynapenia, 6% per decade loss of lean body mass. And aerobic activity is not sufficient to stop this loss. So if you are hoping that you're doing aerobic activity as many as you like, it's still not possible to stop or decrease the muscle mass loss with this training. So you have to do some resistance training. Only resistance training can overcome this loss of mass and strength. Balance and flexibility training contributes to exercise capacity, but focusing on the muscle mass, you have to do resistance training. So what is resistance training? Resistance training is a form of physical activity that is designed to improve muscular fitness by exercising a muscle or a muscle group against an external resistance. In fact, resistance training is containing many different types of exercises inside, like strength training, power training, very different types of application. You can use body weight, free weights, resistance elastic bandages, or anything you may like, pneumatic systems. So anything that will create resistance against the muscle group or a specific muscle, then you can do resistance exercise. And the fact that, as I told, aerobic training isn't enough. We need progressive resistance training to fight with these loss in strength and muscle mass. In spite of these facts, known by most of people, most of the community, the importance of resistance training was neglected. ACSM physical activity guidelines was revealed in 1978, but American College of Sports Medicine, ACSM, and ACSM and American Heart Association revealed the specific strength training advices in 2007. So there is a almost 30-year gap between activity guidelines and specific strength training advices. And behavioral risk factor surveillance system made the first aerobic activity assessment in 1984, but the same system made the first resistance training assessment in 2011. So really the importance and the application of resistance training in health was very neglected by the community for a long time. With resistance training, we have good news, like resistance training improves strength by a range of 40 to 150%, lean body mass increases 1 to 3 kilograms, muscle fiber area 10 to 30%, and it can increase muscle hypertrophy, motor unit activation, motor unit firing rate, and finally strength and power, mobility, functional capacity, cognition, general wellness. And as a result of all these parameters, increased parameters, it will improve the quality of life. Increased strength even in the oldest of old and frail elderly. This is also very important. All these studies are made with people who are older than 90 years old. But even for these people, even for frail older people, if there is always a resistance training program that can be used, and you can still see the positive benefits of the exercise, resistance exercises, in even at this age group. Osteoporosis, osteoarthritis, falls, coronary arterial disease, hypertension, diabetes, metabolic syndrome, the risk of all these problems will decrease with resistance training. There are many studies showing these situations. So it should be a part of the training routine for every elderly. And at the end, resistance training decreases the risk of overall mortality, as I said. And so what we should do, what do we need to be taken care of? We have to understand at first what type of training we have to do for the elderly. It should be a strength training program with resistance or a power training program. The results of the studies are showing power is more important than strength for functionality, like climbing stairs, gait speed, standing up, and so. And lower resistance, higher speed exercises are showing better results for functionality. So especially what we are talking about strength and power training, we have to understand the meaning of strength and power. So a measure of how much force you can generate against an external load is strength, but power is a measure of the speed with which you can generate your peak muscular force. So speed parameter is inside power, not in strength. So what we should try to do is to improve the power more than strength. So what is the intensity? What should be the intensity for the training? Moderate to high intensity exercises are more effective on strength development. High and low intensity exercises are similarly effective on hypertrophy. But of course, when you're doing in high intensity exercises, the repetitions are less. But when you do low intensity exercises, you have to increase the number of repetitions. But at the end, it's similarly effective on hypertrophy. And the volume of the exercise is very important. When we see short term, 6 to 10 weeks, we see no difference between 1 to 3 sets training. But in longer term, if we continue to train more than 20 weeks, then 3 sets is better. So if we are doing it in a long term, we have to increase the number of sets to be able to see the better results. And 2 to 3 times a week is better than once a week for muscle strength and functionality. So we have to do as long as possible and as frequent as possible in this case. Again, to be able to see the most benefits. But overall, the most important determinant of the muscular improvement is the period of training. I mean, the period that you start and continue training over the years. The longer, the better. The best thing is to start in younger ages and continue all the way to the end. Because if you remember the slide, the graph that I showed, you're going to go to a peak and you're going to go very slowly from this peak. So the best thing is continue as much as possible. But even if you start late, you still have a chance. If you start and if you continue, then it's great. You can still see the benefits. According to the National Strength and Conditioning Association consensus, which was made in 2019, a well-organized and programmed resistance training is safe for healthy older adults and should follow the principles of individualization, periodization, and progressions. These are all already the most important parameters of any training program. And this program should include 2 to 3 sets of 1 to 2 multi-joint exercises per major muscle group, 70 to 85% of 1 repetitive maximum, 2 to 3 times per week, including power exercises performed at higher velocities in concentric movement with moderate intensities, which is in between 40 to 60% of 1 repetitive maximum. And this program can contract the age-related changes in contractile function, atrophy, and morphology of aging human skeletal muscle, can enhance muscular strength, power, and neuromuscular functioning of older adults, can improve mobility, physical functioning, performance in activities of daily living, and preserve the independence of older adults. This is very important because for the older adult, especially for oldest of all older, independency is the main parameter that is showing a high quality of life. So we have to preserve, we have to try to preserve the independence of the older adults to be able to increase first the quality of life and then life expectancy. can improve an older adult's resistance to injuries and catastrophic events such as falls. There are many studies showing that resistance training programs are decreasing the risk of fall. So risk of fall, falling in elderly is a very major problem because it's not just for mortality, it's very important, not just for mortality, but also for morbidity, because it creates very serious consequences, very catastrophic consequences. And it can also improve the psychosocial well-being of older adults. There are again many studies showing that resistance training is not just for physical health, but it's also for mental and social health. It's really improving the quality of life by improving the mental and social side of the life as well. And we have to understand and we have to remember this, resistance training can be adapted for anybody. With frailty, mobility limitations, cognitive impairment, or any other chronic conditions, there is always a program that can be applied to these people. The problem is, individually, you have to prepare the perfect program or proper program for this person. You have to understand the problem of the person, and then you have to arrange the program according to the needs of this individual. It can be adapted to accommodate older adults residing in assisted living and skilled nursing facilities. So even if they are dependent of other people for daily living, you can still put some resistance training in their life, in their daily schedule, and they can still see the benefits of resistance training. Thank you very much for your patience. Thanks a lot.
Yes.
Yeah.
Yes. Any questions, madam? Any questions to Dr. Hazan Hulas, Luis? Just if you have any questions, you can text in chat box. We'll be playing behalf of you. We'll be asking behalf of you, even after the completion of the conference. Yes. Thank you very much, sir, for participating in this event.
Thank you very much. Thanks a lot.
Yes, on behalf of organizing committee member of Physiotherapy Congress 2021, we want to thank you for excellent presentation. Looking forward to you next time, sir.
Thank you very much. Thanks a lot.
Yes.
Bye-bye.
Yes, thank you very much. Have a nice day, sir. Bye.
You too. Thank you very much.
Yes.
Thank
you.
Everybody.
Yes, thank you very much. As you know, you are having a busy schedule. You have joined this event.
Take care.
Yes. Now we welcome Dr. Georgios Kakawa from Physiotech Spine and Sports Lab from Greece to presentation.
Hello.
Yes, sir. You can start presenting.
Can you see the presentation?
Yes, just be online, sir. Just be online. Yes, sir. You can start uploading your PPT.
Are we ready?
Yes.
Hello?
Yes, sir, you can play from your side.
Okay. It is an honor to be here. Hello from Athens, Greece. We will talk about neuroplasticity and sports injuries, what is happening with the implication and the future directions in the physio profession. This is a totally new issue in physiotherapy, the neuroscience into the sports injuries and the rehab. And also we will talk some things about sports performance. So fact number one, that the human brain is only 2% of the body weight, but it receives...
Excuse me, sir,
Yeah.
we are unable to see your PPT. No PPT on the screen.
No?
We are unable to see your PPT. Just start sharing your PPT.
Can you see now?
No.
What about now?
Yes, we can find your desktop, sir. We can see your desktop.
Okay.
Yes, it's fine.
Okay.
Yes, you can go. It's fine.
Is it okay now?
Yes, it's okay, sir. It's fine.
Okay, thank you very much. So we will talk today about the neuroplasticity of the sports injuries, what is happening in the physio profession, and we will talk what is happening with some things regarding the sports performance in the brain. I cannot... It's stuck. I don't know why. Can you play from your side? Hello?
Yes, sir, you can start.
No, it's stuck. I cannot play from my side my PPT. I don't know why. Okay.
Yes, it's fine.
So, fact number one, the human brain is only 2% of the body weight, but it receives 15% of the cardiac output, blood, 20% of the total body oxygen consumption, and 25% of the total body glucose utilization. So the brain is the most metabolically active organ of the body. Fact number two, we talk about that the brain is plastic, and we're referring to neuroplasticity. The definition is that our brain has the ability to change, adapt, and learn. So every time we learn something, a new skill, or after an injury, we learn a new movement, we change our brain. Fact number three, after every time we learn, so we create new pathways or circuits in our brain. So learning the brain drives change in a structural way, but also in a chemical way. Fact number 4. When we're practicing, we're developing pathways inside our brain. So the practice regarding sports performance, regarding sports, or after an injury, create changes in our brain. Everything we learn in everyday life, like a bicycle, like a new music song, a music instruments, or new movements in our sport, creates and reorganize our brain. Why we talk about neural hierarchy in the sports rehabilitation? Because the brain organizes the sensory input with 3 systems: the visual, which is on the top of the pyramid, the vestibular, and the proprioceptive. All those years, or all our efforts with mechanotherapy, with massage, dry needling, acupuncture, manual therapy, chiropractic, all these, we stimulate the proprioceptive system. And we have left the vestibular and the visual system outside of this, and we will see in the next screens what is happening when we left outside our rehab programs and sports performance programs, the vestibular and visual systems. So the visual system is vital for our survival. So when discussing visual skills in sport and rehab, it's not what we see, but what our brain is processing after we see a scene. And this is the thing. It's not about vision. Vision is the processing of visual information, but with neuroplasticity in mind, the visual processing changes everything in our brain. So the skill in moving our eyes is from the first skills we have after we're born. And the same thing happens with proprioception. We're starting to move, but the visual is the first part of our neurological pyramid. So vision is a vital component to that. And we don't train or retrain our visual skills and our balance skills. Of course, balance, we have some things in our rehab programs, but the visual skills, it is forgotten in our rehab programs. Sometimes the 2 systems, the visual and vestibular, they are working together like an orchestra. And an injury can disturb the 2 systems. And all the rehab programs must have those 2 systems working together. So when I have to rehab an injury, an ACL injury, I have to make the skills of an athlete, or vestibular skills first. So he can balance without visual input, close eyes, turn the head where the eyes are looking, moving the head on different axes at various speed with eyes open and closed, and moving the eyes when the head is still. All these components and movements are very critical for our performance. So the new concept is the neurology of performance and rehab. And the study of this new essay in rehabilitation is to improving brain function and to achieve high level of performance. with when we train the brain, when we stimulate the brain, we have better results in rehab, and of course, better results in sports performance. Why? Because the sport happens in motion. So sometimes in sports, the athlete must track objects and react quickly and accurately as possible, and of course under pressure. So sometimes when he tracks the object, he must anticipate the next move. Sometimes the injury happens there when he lost the motor control, and that's why we talk about that some serious injuries like ACL, they are brain injuries, they are not knee injuries. Same happens with the balance, is the ability to maintain the line of gravity from the center of mass, but it is a multisensory system, including the vestibular system, the somatosensory system, and the visual system together. So the visual and vestibular information ranks very high in the brain. Those two things must train together like an orchestra, like you said before. The proprioception is at the bottom of the pyramid. So specific vision and vestibular training is vital for athletes who want to get better after an injury. One thing we must consider in our rehab programs is the PMRF, the pontomedullary reticular formation. Why? Because when we do something with one side of the body, the other side of the body must be stabilized. The other things that PMRF does is that controls the sympathetic activity. Also controls posture above the T6 and below T6. And PMRF, of course, controls the muscle tone and among others. In some athletes, the PMRF, when it's not working well after an injury, after an ACL, can increase the sympathetics. That means the blood pressure, the heart rate, the sweating of one side, it will be more than the other. This is weird for the athlete. And because we have a situation called sympathetic dominance, this is bad news for athletic performance and healing. So every musculoskeletal problem is a brain problem. Body training and body rehab increases proprioception only, fitness, strength. Sports rehab with passive mechanotherapy increases proprioception. All injuries decrease proprioception with correct remapping. So for the athletes, the best thing to rehab them is to train all the three systems together in integrated fashion. This is one paper, one of the first papers talking about if neuroplasticity of the central nervous system is the missing link to understand chronic musculoskeletal injuries, and explains that neuroplastic changes in different areas of central nervous system maybe help to explain the transition from acute injury to chronic condition, sensory motor findings, perceptual disturbances. So this is a very good paper, and it explains very good how an acute injury can become a chronic one. This is our work in the neuroplasticity of musculoskeletal injuries. It is published in the Indian Journal of Orthopedics, and we talk how we can add all those things I talked before in this review. And this is another paper of our team, that explains that in the periodization of anterior cruciate ligament, we must add a new phase. We have some phases. That's why we talk about novel framework. The new phase is the neuroplastic phase. I can invite you, because I'm finishing my presentation, in the European College of Sports Physicians conference this year, happens in Athens, Greece. This is the biggest sports medicine event of the year. Many rehab and sports medicine physicians from different clubs like Barcelona, Bayern Munich, Chelsea Football Club will join as speakers this big event. Thank you for your attention. If you have any questions, I will be happy to answer.
Yes, sir. Any questions? So, any questions to Dr. Georgios Kakawa? I think no questions, sir.
Okay. Okay. Thank you very much.
Yes. Thank you. Thank you very much, sir.
Thank you very much.
Yes. We truly value your presentation. And on behalf of our organizing committee member of Physiotherapy Congress 2021, we want to thank you for your presentation. As having with a busy schedule, you have joined this event for 25 minutes. We truly value your presentation. Once again, we look to forward to meet again next time. Now we request Dr. Syed Wahidi from Sports Medicine Center from Astan Quddus Razivia Institute of Physical Education from Iran to start the presentation, sir. Hello, Dr. Syed. Just you can start your presentation. Is Dr. Zahara is ready with PowerPoint presentation? If you are ready, you can start presentation, madam. Not an issue according to the scientific program, because we do have more three talks left for this day. If you are ready with the PPT, you can start presenting. Yeah, Dr. Syed, you can start your presentation. Hello.
Greetings and respect to all ladies and gentlemen presented at the webinar. I am Saeed Wahidi, manager of Sports Astan. Greetings and respect to all the ladies and gentlemen presented at this webinar. I am Saeed Wahidi, manager of Sports Medicine Center of Astan Institute of Physical Education.
Yes, sir. You can proceed with your point.
Greetings and respect to all the ladies and gentlemen present at the webinar. I am Saeed Wahidi, manager of sports medicine and center of Astana Rajavi Institute of Physical Education in Iran.
Yes, but we don't see you don't find to see your PPT on the screen, sir. Just you can start sharing your PPT. It will be good to us to hear what you are saying.
Yes. I will share in a moment. Okay. You have our PowerPoint?
Yes.
Okay.
You can start.
Yeah, greetings and respect to all ladies and gentlemen presented at the webinar. I am Saeed Wahidi, manager of a Sports Medicine Center of Astana Rajavi Institute of Physical Education in Iran. My topic for presentation at this webinar is comparing temperament, massage in persons with shin splints and healthy male and female students at Firdaus University of Mashhad. As introduction, I say complementary and traditional paying to individual differences is one of the most important principles of therapy and prevention. Iranian medicine is one of the branches of complementary and traditional medicine, which is a complete integrated medicine, Hippocrates, that was developed by the great Iranian scientist Ibn Sina. Ibn Sina believes that for health and well-being, special attention should be paid to temperament, nature, which can be rooted in one's inheritance. Based on his temperament pattern, he has proposed diseases and complications. In this model, he says most of complications and diseases are caused by imbalance in temperament, the nature of organ or their whole body. Temperament is based on the building blocks of universe, which include water, fire, soil, and air, which vary in quantity and quality according to the inheritance of individuals. Warm and dry, warm and wet, cold and dry, cold and wet, are the four temperaments in Iranian medicine. In the theoretical foundations of Iranian medicine, each person's temperament is a set of unique physical, anthropometric, and psychological characteristics. Accuracy of individual differences rooted in heredity is one of the most important principles of traditional and complementary medicine. Temperament for the human body can be divided into two types of organ temperament and general temperament. That the general temperament of the body is the result of the main organs temperament of the body, heart, liver, and brain, while other organs of the body have a constant temperament. By disturbing the temperament of the organ, of that organ, a complication and disease is created for it. Like a bone that has a dry and cold temperament. If the amount of dryness and coldness is less than normal, one complication will appear. And if the dryness and coldness are more than normal, another complication will appear. Based on the rules of temperament, Ibn Sina has proposed effective and practical strategies and instructions for therapy and prevention. One of these complications can be called shin splint. Although running has many benefits, it has its drawbacks like any other sport. Injuries that occur while running include overuse injuries, one of the most common of which is shin splint injuries. Shin splint is a pain that occurs during activity, especially running and jumping, and disappears with the rest. This pain occurs on the side of tibia, usually the middle third, and exacerbates during plantar flexation. This pain lasts for a few hours to a few days. Some factors are considered to be involved in the possible occurrence of this pain, which are expressed in two groups of internal and external risk factors. Among the external risk factors, type of activity, intensity, type of activity, type of playground, show type, weather condition, speed of training, time of activity, and amount. Internal risk factor, repetitive and high running. Previous injury history, increase external rotation in the ankle, increases plantar flexor muscle strength, increase internal rotation in the front or back of the foot or both. Gender incorrect techniques, decreased bone mineral, high body mass, and an antecedent that may be involved in the development of shin splints. By controlling external risk factors and paying attention to individual differences, I mean temperaments, which is a subset of internal risk factors, it is necessary to compare temperament in persons with shin splints and healthy. This is a descriptive study, and the subject, including 238 non-athlete students aged 19 to 23 years, were selected, and their temperament was determined using a standard questionnaire. Their demographic information is reported in Table 1. Of these, 144 were men, 89 were healthy, 55 were shin splints, and 94 were women, of which 50 were healthy and 44 had shin splints. Subjects had general health criteria and the absence of deformities of the genovarum, varum hollow foot, flat foot, and complications affecting the aggravation of shin splints, including foot pronation, who lived in the student dormitory of Ferdowsi University of Mashhad. People with pain along the inner posterior edge of the leg in the middle third of it that occurs during exercise, and this pain lasts for hours or days and spreads over an area 5 centimeter length, and usually after 300 meter running, this pain occurs. People had shin splints. A temperament questionnaire was distributed among the participants. Before completing the questionnaire, information about that was explained to each person. Subjects were nutritionally consistent with almost identical meals, so that the nutritional differences did not significantly affect people's temperament. Kolmogorov-Smirnov test was used to ensure the normality of data. 11 test was used to confirm the homogeneity of variances, and finally, chi-square test was used to analyze the data. All these steps were performed by SPSS software version 23. As it is seen in the tables, the results indicate that there was no significant differences in cold and hot temperaments between the groups with shin splint and the healthy group. But a significant difference was observed between the two groups of dry and wet temperament. The prevalence of dry temperament was higher among people with shin splint than healthy people. Discussion. Ibn Sina, in his book called Law, introduces bone tissues in terms of temperament, first dry and then cold. This means that people with a cold temp are more likely to have bone damage than people with a warm temper, because the temperament of the bone is cold, and according to teachings of Ibn Sina, When a person's temperament is the same as the temperament of the tissue, the probability of injury part of the body increase. For this reason, Ibn Sina advises people with a cold temperament in the winter use foods with a warm temperament so that the cold winter cannot have a potential effect on a person's health and did not cause bone damage in person. Although the results of the study did not have a significant relationship between with cold temper, but people with cold temper were more likely to suffer from shin spleen. The descriptive results of the study showed that dry temperament has a significant positive relationship with shin spleen. According to the findings of Tweed and Hubbard, one of the causes of shin spleen is a decrease in bone density. It is possible that dryness reduces the body's water and electrolytes and increases bone dryness, and that bone tissue loses water and the electrolytes needed by the bone, thus are reduced. Bone flexibility in the face of stress from daily activities and exercise and cause bone damage. Conclusion, the complication of spleen regardless of environmental factors can be seen more in dry tempers. Also, this complication is complementary and traditional medicine can be attributed to the increased dryness temperament of tibia, which is aggravated by the increase in dry
سعید
temperament of
یه چیز واسه تو واتساپ فرستادم دوباره واسه من
This complication can probably be treated with the measures contained in Ibn Sina's law book on medicine to prevent excessive dryness of tibia. Our future works include the types of inflammation in joints and how to deal with it properly in the treatment and preventive traditional and comparative medicine. I hope you are healthy and safe for your attention.
ask you to start the video. خب من میخوام شیر کنم چیزمو.
Yes. Any questions? Yes. Any questions to Dr. Syed Wahidi? Yes. Thank you very much, sir, for participating in this event. On behalf of Organizing Committee, on behalf of Organizing Committee, yes, on behalf of Organizing Committee of Physiotherapy Congress 2121, we want to thank you for your instant presentation. And kindly note that Dr. Syed Wahid is joining this event for second time. Congratulations, sir, for sharing your valuable experience in front of this audience. Thank you so much for speaking up in this meeting and providing your own perspective. You'll be a gentle response to whenever we mail from our side. Thanks for sharing your tips with us. Looking forward to meet again next time. Yes, now we ask Dr. Zahara Moinishfar from Faculty of Sports Science from Ferdowsi University of Mashhad from Iran to start the presentation.
Excuse me, can I can't send my document share.
Just you can, will you send your PPT through WhatsApp number, madam? Immediately we can play behalf of you.
Okay. I sent your WhatsApp.
Send me immediately.
Yes, I sent my PowerPoint to WhatsApp. for Mr. Kevin.
Just be online. Just be online. I'll be checking all those. ఇప్పుడు పంపించండి కొంచెం. Yes, madam. Is it visible to your? Yes.
Okay, yes,
You can
it's
proceed.
visible. Um,
Yes, you can start your presentation.
in the name of God, greeting. Okay. What? Excuse me. Can I start?
Yes, you can start. After the completion of the every
Okay.
slide, just you mention next change. I'll be changing from our side. Yes, you can start.
Okay.
Yes.
In the name of God, greeting and respect to all the ladies and gentlemen present at the webinar for physiotherapy, physical rehabilitation, and sport medicine. I am Zahra Moin Afshar, Master of Sport Injury and Corrective Exercise from Ferdowsi University of Mashhad. And my topic for a presentation at this conference is the comparison of the effect of 8 weeks comprehensive corrective exercise with open and closed kinetic chain on tibial internal rotation and femoral medial rotation in girls 8 to 12 years old. Researchers have all long been particularly interested in studying human movement because movement and activity have fundamental and vital role in human life, and reduction of mobility and physical activity is associated with a variety of disease and physical and mental disorders in human. And these problems must be addressed at great expense. One of the problems of this inactivity is various physical abnormality. Excuse me, I can't my picture. I can't see my picture.
Yes, you cannot see your picture, madam, because you are playing.
Okay.
Yes. You can
Okay.
start.
Provide the ground for their injuries, especially musculoskeletal abnormalities in the lower extremities that negatively affect a person's functions such as walking and running. Musculoskeletal abnormalities are caused by lack of mobility, receiving peripheral stimuli, as well as inappropriate movements. Pattern and leave adverse effect on psychological, social, and physiological functioning of individual disturbed. Optimal physical condition is condition in which different parts of the body are most efficiently self-disturbing the function of other parts of the least energy consumption and less fatigue. Change in the right direction, increase stress. If the stress enter for a long time, the body structures will change and cause abnormalities in the body. Internal rotation is one of abnormalities of the tibia and femur. Is a very common abnormality that leads to a change in the proper direction of the lower limb. The alignment of the foot as the most distal part of the lower extremity motor change plays an important role in the standing, walking. It has been argued that muscle imbalance and stiffness play a role in causing these abnormalities. Recently, it has been suggested that increasing hip strength may reduce additional movement of the distal area away from the lower limb trunk in the transverse and frontal planes. Hip movements are the most influential factor in the movement of the posterior parts of the foot. Because when the area away from the trunk of the lower limb is fixed on the surface, movement in one of part of affects other parts of the movement change. One of the methods used to correct and treat these abnormalities is corrective exercise. Corrective practice or exercise is a term used to describe the systematic process of identifying abnormalities and defects in neuromusculoskeletal function during other things. Corrective exercise are performed both comprehensive and locally. Topical corrective exercise are exercises that, according to Kendall theory, are designed solely to reduce the effect of a particular anomaly and to correct the tissue around it without considering other problems associated with the anomaly. Such training programs often include stretching and stretch training. Comprehensive corrective exercises are exercise that, in addition to reducing the effect of the abnormalities in one joint and point, simultaneously correct other related musculoskeletal disorders and resulting abnormalities in other parts of the body. According to the concept of Vladimir Janda, chain reaction, which refers to the interaction between skeletal muscular and nervous system, the occurrence of any defect in any of the joints and the muscles of the body can affect the quality and function. Other joints and muscles are also affected. Therefore, in addition to the involved position, general and comprehensive attention should be paid to other organs and joints of the body. Various exercises have been suggested to perform corrective exercise such as open and close movement change in recent years. The concept of movement change training has been considered as an effective and useful rehabilitation technique, especially in lower limb injuries and abnormalities.
Excuse me, madam. Excuse
Oh,
me.
fine.
Just
You're welcome.
Yes, when you are changing the slide, please mention so that I can change your slide, because I was confusing.
Oh, okay.
Just tell me the change slide. It's enough. I will be changing.
Okay. The joint of the wrist, the knee, and thigh form the motor change of the lower limb when the end of the limb is fixed, such as when the foot bears weight on the ground. The change of motion is called close. A resistance is required in both the distal and proximal segment so these exercises are superior in producing a stretch. Conversely, in an open kinetic change, the end of the limb is movable and not fixed. Features of open kinetic change exercise include increasing acceleration forces, reduction of resistive force. The effect of comprehensive corrective exercise on other abnormality has been proven, and also both open and closed kinetic change exercise have their own place in corrective exercise, determining the superiority of training in each of the open and closed kinetic change. An exercise can be considered as an easy and accessible method in correcting the internal rotation of the tibia and femur. Rotation of the tibia and femur is a twist or rotation of tibia and femur around its longitudinal axis. In tibial internal rotation, a large deviation is observed in the angle of progress of the foot, the angle between the direction of the sole of the foot and the forward line. In this way, the toe is closer to the center line than the heel. Physical, psychological causes from this abnormality, lower limb rotation is largely hereditary. Also, some studies have suggested neuromuscular disease and knee various as other causes of rotational changes. Sibulka in 216 conducted a study entitled predicting the relationship between hip and tibia rotation angle and walking angle in 60 healthy adults. and in 2017 in a study examining the relationship between femur and tibial rotation rates in patients with unilateral hip dysplasia. Most in general, past research has shown that one abnormality prediction to another limb abnormality. This abnormal routine begins in childhood and take on a steady form in adulthood. Research have shown that performing open and closed corrective exercise have positive effect on corrective lower limb abnormalities. This exercise also reduce lower back pain, improve muscle activity, and deep sense. The aim of this study was to compare the effect of 8 weeks of comprehensive corrective exercise in open and closed kinetic chain on internal rotation of the tibia and femur in girls aged 8 to 12 years old. This research was conducted by quasi-experimental method and applied goal type and in the field, and was done with pre-test and post-test design. For this purpose, in the target population after diagnosis, the internal rotation of the tibia and femur, the condition for entering the research by specialists. They feel in the consent from to participate in the research. Based on the data of G-Power software, 20 people were selected. From these people in a purposeful and accessible manner, and randomly divided into 2 experimental groups. One group's open kinetic change, 10 people, and one group's closed kinetic change, 10 people were divided. At the pre-test, in internal rotation angle of the tibia and the internal rotation angle of the femur were measured with a goniometer. After 8 weeks of comprehensive corrective exercise in the open and closed chain based for NASM protocol, the research variable were measured again. Participants participated in all comprehensive open or closed kinetic change based on NASM training program, and in 24 researcher supervised training session. There are 45-minute session per week. Each training session includes a standard warm-up exercise and a stretch training exercise. Raw data were analyzed after collecting and interning information in SPSS 25 software environment. Shopperwick test was used to determine the normality of the data, and then to compare the analysis of variance with repeated measure and univariated analysis of variance at the level significant p less than 0.05 was used. Typhoid method was used to measure the tibial internal rotation. The subject lies on the stomach, on the chest bed, and the knee joint is flexed at 90 degree, and the center of the heel is marked on the plantar surface. And divides into two equal halves. Draw and the angle between these two lines is recorded. The measure the internal rotation of the femur. The subject was placed on a bed lying on this on his stomach, and the subject was asked to bend his knee until the angle between the knee and the femur reached 90 degree. The subject is then structured to perform the internal rotation of the end of the range of motion. The result of this study showed that decreased internal tibial rotation angle was observed in the post-test in both groups of open and closed chain corrective movement exercise P less than 0.001, and there was no significant difference between the two groups of open and closed chain exercise P less than 0.05. Reduction of internal rotation angle of the femur was observed in the post-test after corrective exercise in both open and closed chain groups, P equal 0.001, and also a more significant difference was observed in the closed chain exercise group, P equal 0.031. One of the problems that creates the wrong way of sitting in the shape of W and causes the patella to rotate inward is the internal rotation of the tibia, which in acute causes can be surgically and in semi-acute condition can be corrected exercises return to normal. Kajewski in 2080 shows that closed chain groups exercise including lower limb muscle resistance when performing dynamic movement, as well as a specific high muscles exercise had positive result to help improve the process of his complication, which is consistent with the results of the present study. Michael, 2060, in a study of the relationship between the rotation angle of the femur and tibia and the degree of angle of process of the foot while walking, and showed a moderate negative correlation between the degree of internal rotation of the femur and the tibia and the degree of angle of progress of the foot. Walking is associated with inward claws. The amount of external rotation of the tibial is also related to walking with outward pulse. Therefore, it seems that by correcting the angle of rotation of the femur and tibia, the angle of progress of the legs and the toes inward is also corrected. and by stretching the stretch muscles and shortening the stretch muscles, it helps to improve this complication and close muscle stretching exercise. In close chain exercise, the joints and muscles are involved, and the same time by stretching and stabilizing the joint, the extra ligament pressures are reduced as recent closed chain exercise are effective movements in joint rotation problems. In the open movement change, due to the fact that the support of movement is mostly with sports devices. So by performing a level measurement of the occurrence of the problems, it is possible to change the joint rotation step by step. The femoral internal rotation leads to increases anteversion abnormality. This rotation of the femur also causes the foot and the patella to rotate inward. In this study, closed and open change exercise had a significant effect on this complication, and more progress was observed in the closed chain group. The results of the research are in line with the researches of Ayuma 2019 and Dadashpur 2012. The results of this study, by increasing the stretch of the external rotator cuff muscles of the thigh and abductor, and using training intervention, the inwardly rotated leg can be corrected, which is consistent with the results of the present study. And one of the possible reasons is the effect of corrective exercise on quadriceps. When the foot is resistant or fixed, the initial part of moves in a predictable pattern, and the comprehensive factor are gradually first from the end of the top of the chain. If the foot moves freely in a space, the movements that take place in other parts of the change are not necessarily predictable and not affected by the position and the function of the end part. In open change training, the origin of the muscle is fixed, and the contraction of the muscles creates movement at the site of adhesion. In closed change exercise, the adhesion site is fixed, and the muscles works to move the initial part. The concept of reversibility of muscles function and simultaneous displacement used for biceps muscles that have different muscular function within the motor change and during weight-bearing activities are indicator of closed motor change exercise. Closed change exercise include simulating more natural biomechanical and physiological physiological function, increasing joint comprehensive force, that increasing joint homogeneity, and thus increasing joint stability, reduction of shear force, reduction of acceleration forces, and large resistance forces, stimulation of proprioceptors, and increased dynamic stability are all associated with weight bearing. There is no adapt that follows movement change exercise, include exercise that are more closely related to the desired functional activities. In the field of sports medicine, the specialty of the exercise should be emphasized in order to maximize the transfer of training results to functional activities. Most open change exercise are used to develop muscles strength with little attention paid to deep sense and the sense of joint position. Future work, the effect of compressive corrective exercise in open and closed movement change on other lower and upper limb abnormalities should also be investigated. The electrical activity of the muscle before and after the open and closed chain be compared and examined. A follow-up test be performed to evaluate the durability of the effects of open and closed movement change exercise in the long run on research variable. Finish. Thanks for watching. Thanks for from all audience.
Yes. 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 Any questions? Any questions to Dr. Zahara? I think no questions, madam. No questions.
Okay,
Yes.
thank you.
Thank you very much, madam. Thank you very much for participating in this event. On behalf of organizing committee member of Physiotherapy Congress 2021, we want to thank you for incentive. Looking forward to meet again next time in physical event if everything goes well.
Thank you.
Yes. Yes. No, we asked Dr. if possible, Dr. Mariam Sadat from Avahas University of Medical Science from Iran to start the presentation. If you are okay from your side. If you are okay with from your side, you can start presenting, madam. Or else we will be closing the ceremony. Yes. Yeah, Dr. Mariam Sadat. If possible, you can play from our side.
Hello everybody, I'm Mariam Saadat, Assistant Professor of Physical Therapy in Ahmad Janishapur University of Medical Science. I'm going to present the original research about cervical movement kinematic analysis in patients with chronic neck pain in comparison with healthy controls. Neck pain is the second musculoskeletal disorder after low back pain. Patients with neck pain often difficulty in completing an accurate and full range of motion during walking, driving, and reaction to surrounding stimuli. Previous studies have shown reduced velocity, range, and smoothness of movement in individuals with neck pain. But they examined the kinematic of fast cervical movement. But most daily activities are performed at natural pace. Also, they examined both whiplash and idiopathic neck pain groups, but they weren't same groups. In result, the aim of this study was to compare the cervical kinematic measures in
Please next slide. We can't play it. Do you hear my sound?
Yes, yes, madam. We do hear.
Please next slide. No, it's not mine.
Just beyond that.
Thank you.
Hello everybody, I'm Mariam Saadat, Assistant Professor of Physical Therapy in Ahmad Janishapur University of Medical Science. I'm going to present the original research about cervical movement kinematic analysis in patients with chronic neck pain in comparison with healthy controls.
Please next slide.
Neck pain is
Yes,
the
it's going
second
to share.
musculoskeletal
I can move it.
disorder after low back pain. Patient with neck pain open.
Is it okay?
Difficulty completing an
Yes.
accurate and full range of motion during walking, driving, and reaction to surrounding stimuli. Previous studies have shown reduced velocity, range, and smoothness of movement in individuals with neck pain. But they examined the kinematic of past cervical beats. But most daily activity are performed at natural pace. Also, they examined both whiplash and idiopathic neck pain groups, but they weren't same groups. In result, the aim of this study was to compare the cervical kinematic measure in individuals with or without chronic non-specific neck pain at a natural speed. The second aim was to determine the associations between pain, disability with cervical kinematic measures in patients with non-specific neck pain. The study had a cross-sectional design which kinematic performance of 20 patients with chronic non-specific neck pain compared with 20 healthy controls. We matched controls with the patients according to age, height, and body mass index. All participants signed an informed consent form which approved by the Ethics Committee at Ahvaz University of Medical Science before commencing the study.
We did next slide.
Patients include if they were diagnosed as non-specific neck pain, age range between 80 and 50 years old, and history of neck pain more than 3 months. The participants were excluded if they had a history of cervical spine surgery, whiplash injury, spinal deformity, cervical radiculopathy, rheumatic disease, neurological disorder, and severe pain in other body regions. Procedures. Participants were instructed. Cervical kinematic data were recorded by a 7-camera motion analysis system with a sampling frequency of 60 Hz. Retroreflexive markers were placed 2 on forehead, 3 per cluster on mid-forehead, left and right temporomandibular joint, and 1 on C-half spinal process. Procedures. Participants were instructed to stand barefoot with arms crossed over the chest and their foot open at shoulder width. They were instructed to close the eyes and place the head in a neutral position for 2 seconds. Then be asked to perform active neck movement in one of 4 directions: flexion, extension, rotation to the left and right 3 times at a self-selected speed after hearing a beep tone over the maximum pain-free range of motion. Outcome measure were time, cervical range of motion, peak velocity, jerk index or smoothness of movement, visual analog scale is 10 centimeter line that represented pain intensity, neck disability index is 10-item questionnaire that measured the level of disability of neck patients. The MATLAB program was used for analysis. A statistical analysis. Normal distribution of data were tested using the Shapiro-Wilk test. Independent sample t-test and minority u-test were used to compare the outcome measures between the groups. Pearson correlation coefficient was calculated for the normally distributed variable and Spearman correlation for the not normally distributed variables. The result: demographic and clinical data of participants
Next slide.
with chronic neck pain and healthy control is shown. There were no difference in the age and body mass index between two groups.
Next slide.
Finding our study showed duration of movement was significantly greater during right rotation in neck pain group than healthy control. Neck pain group had significantly lower peak velocity during flexion and right rotation. Range of motion was significant difference between two groups only in flexion direction. But jerk index was significantly higher in neck pain group in flexion, extension, and left rotation direction than control groups. Please see the chart. Patient group is
Next
shown
slide.
with blue and control group with orange color. This chart demonstrates peak velocity of two groups. Patient groups had lower peak velocity in flexion and right rotation than control group. This chart demonstrates jerk index. Jerk index is higher in chronic neck pain than control group in 4 direction. But right rotation wasn't significant statistically.
Next slide,
The
please.
result of the correlation analysis showed the pain intensity was moderately correlated with duration, range of motion, and jerk index. Neck disability score was moderately associated only with peak velocity in right rotation. A strength of correlation interpreted by categorization of Q. Here state 0.2 to 0.49 is fair to moderate correlation, and 0.5 to 0.74 is moderate to good correlation. The results of this study are these two range. Question? Some possibility may explain the altered cervical movement pattern among patients with chronic neck pain. First, it may be related to altered motor control strategy among these patients. Previous studies have been shown inhibition and delayed onset of the deep neck flexors with higher activity level of superficial neck flexors that could result in co-activation of these muscles. The current study had some limitation. First, the psychological aspect of pain, such as kinesiophobia and fear avoidance belief, were not considered. Second, high pain intensity in the neck pain group may limit the generalizability of the present study's findings. Future studies should explore kinematic performance in people with chronic neck pain with lower pain intensity or in pain-free period in larger samples. Conclusion. The study's findings indicated altered cervical kinematic performance, particularly reduced smoothness of movement during naturally paced motion in patients with chronic non-specific neck pain compared to asymptomatic participants. Also, pain intensity was moderately associated with most kinematic measures. These studies' results can help to understand better the impairments associated with chronic non-specific neck pain. Thank you for your attention.
Excuse me, my quality of sound is bad.
Yes. Any questions? Yes. Any questions to Dr. Mariam Sadat? Yeah, doctor will be answering the questions, answers from here only. Just we have left only 12 participants in this conference are present. The drawback is as soon as they're completing their talk, they are just leaving from the Zoom meeting, madam. That is a drawback. Yes, any questions? We asked Dr. Ebe, Dr. Sergio Baronk, Dr. Fatima, if you have any questions, you can ask from here. So we'll be closing the meeting within 5 minutes. You'll be getting electronic certificate, e-certificate as well as book within a couple of days. Yes. Thank you very much, madam, for participating in this event. On behalf of Organizing Committee member of Physiotherapy Congress 2021, we want to thank you for instant presentation. If you go to vote of thanks, thank you very much to all the participants, those who joined this webinar on second virtual conference on physiotherapy, physical rehabilitation, and sports medicine during this period having with different time zones. Our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, general collaborators, media partners who have joined from different destinations around the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitations to participate in this conference. We have received several papers which will inform the basis of our discussion in the various sessions. Let us thank you all for associating with this conference by your presence. A special thanks to Program Manager, Mr. Kevin Brown, for his continuous effort in putting us all together under one platform in this online event. And I would especially thankful to the keynote speakers of the day will be Dr. Steve Bailey, Dr. Azan Ullah House, Dr. Vivan Mushawar, as well as Dr. Georgios Kakawas for joining as a keynote speakers, as well as plenary sessions of the day will goes to Dr. Mohammad Hasim, Dr. Vidhi Thakur, Dr. Nauru Kaur, Dr. Meena Morkos, Dr. Fariba Gadiri, Dr. Ita Doshi, Dr. Kerner, Dr. Heman is not presented due to some technical problem, as well as Dr. Zoltan Alfodi, Dr. Mariam Sadat, as Dr. Deep Salim, Dr. Said Wahid, Dr. Zahara, and the video presentation goes to Dr. Adam Lakhi. And the delegates participants, Dr. Fatima Khalid Hamad, Dr. Tom Frigid, Dr. Habigihe, Dr. Siharvi Baranko, Dr. Gobiano Bersali. And if everything goes well in 2022, hope we will join in physical event on same topic, that will be physiotherapy conference. We are planning in Dubai, if possible by end of this year or in starting of the next 2021. The electron certificate, ebook, as well as electron booklet will be sent through email in couple of days. That may be working days, within 2 to 3 working days after the completion of the conference. Finally, we extend our appreciation to each of you for participation in this online conference. Thanking you. If you have any questions or queries, just you can text in chat box. We'll be sending you all the answers within 1 or 2 working days. This is signing off, Madhu Bhupati. Thank you.